morning.
Hi, good morning, everyone. So welcome to our Children's Safeguarding Teaching Day. We are pleased to welcome all of you, all colleagues from multiple countries and different systems. Thank you for joining us today. This event is organized by the British Sudanese Association of Pediatrics and Child Health, BSAPCH. Today's teaching is designed to help you all of us meet level 3 safeguarding learning needs. The aim of the day, so we will help everyone in recognizing and managing safeguarding concerns, communicating clearly with families and multidisciplinary teams, performing safeguarding medicals in line with current best practice, and also how to deal and handle challenging scenarios, including cases involving child death. The structure will be as follows. So we will start now till about 4 p.m. We will have short breaks throughout. Certificates will be given only if you attend the full course and all lectures, as each session builds your knowledge and they are all connected together. So please make sure you attend all sessions. Please ensure your Zoom name also matches the name you want on your certificate. We will be tracking the name and the attendance as well. Please also complete the feedback form at the end of the session, at the end of the day, because this is required as well to receive your certificate. We are joined by an excellent group of speakers today. This is not the formal introduction to every one of them, but just briefly, we will have first session Dr. Bronnert, who will lead two parts, one big session in two parts about managing safeguarding concerns in clinical practice and how to perform safeguarding medicals, including assessment, documentation, and legal considerations. Then we will have Dr. Muhammed Nadeem, who will discuss communication during different and difficult safeguarding scenarios. Then Dr. Nadia Baasher will present on child death within safeguarding and how to manage these sensitive cases. And at the end, we will have Dr. Habab Makki, who will share learning from challenging safeguarding cases in emergency department. So very important note, today's session is designed at level 3 safeguarding with a focus on some details like child death and performing safeguarding medical. This teaching day is fully accredited by RCBCH and approved for CPD points. All sessions combined will provide you the essential knowledge required for level 3 safeguarding. But also we do recommend to check with your college or professional body to confirm curriculum alignment with your requirements. So now let's get started. Everyone, please take part, ask questions, anything you need or you have a concern about or a question, please put on the chat and we will make sure we get your question answered as much as possible and use today as a chance to reflect and strengthen your safeguarding practice. Now I will hand over to Dr. Habab Makki, emergency medicine consultant in Leicester Royal Infirmary, who will introduce the work of British Sudanese Association of BSAPCH, British Sudanese Association of Pediatric and Child Health, and share its recent activities as well, and also talk to us about the importance of safeguarding. Thank you so much, Habab.
Thank you, Sama. Welcome, everyone. I think it's going to be a busy day. We've got loads of participants, so we'll try and make it interactive and as educational as possible. So BSAPCH is an NGO or international organization, an educational association dedicated to advancing children's care. We uphold the belief that every child deserves access to quality health care, and we're committed to improving the well-being of children, as well as supporting the professionals who serve them. So we have lots of programs, and through our academic and professional program, we provide training resources for MRCPH examination, for STAR assessments, for interview preparation as well, and support mentorship of IMGs and loads of other academic activities that you can find in your YouTube channel. And there will be a link on the chat as well. So I think this day, Usama said, is going to be a full-on activity. It's a level 3 safeguarding and teaching. At the end, there'll be 30 minutes of questions at the end of the day. So you have time to think about what you want to ask, and then we can discuss it later in the day. I think some of you aren't from the UK, and as an IMG as well, I train in Sudan. And coming to the UK, safeguarding was quite a complicated concept for me to understand. But I think for today's session, we're going to try to make you more comfortable in assessing safeguarding cases. I like to say, if you see it, say it's sorted. So if you see a case you find complicated, you see it, you speak to someone about it, and then hopefully you get someone sorted with you. So don't ignore the signs you see of safeguarding signs. One thing I wanted to say is we all think that children are safe and they're protected, but I think the reality is children are quite vulnerable to exploitation. They can be abused as well. So our job as pediatricians to make sure every child is looked after in every context, every country. We might have different contexts, different countries like FGM or child abuse or physical abuse in every different context. But I think our job is to share the learning. So I hope you enjoy today, and I'll hand you over back to Sam again.
Thanks, Habab. So yeah, I think we should start now. So please, Joe, can you please start introducing the first session, and Dr. Dan Bronnert. Thank you.
Hi, good morning, everyone, and thank you for joining us today. It's both an honor and privilege to welcome our speaker, Dr. Daniel Bronnert, to deliver this important lecture on children's safeguarding and safeguarding medical. Dr. Bronnert holds a Bachelor of Medical Sciences and is a member of the Royal College of Paediatrics and Child Health. He currently serves as a pediatric consultant at the Leicester Royal Infirmary, UK. In addition to his clinical expertise, he holds the critical role of Children's Safeguarding Lead for Leicestershire, where he plays a key role in protecting vulnerable children and guiding multidisciplinary teams through complex safeguarding challenges. With years of frontline experience, Dr. Bronnert brings not only clinical insight, but also a deep understanding of the ethical, legal, and practical aspects of safeguarding. His commitment to child welfare and his ability to translate policies into meaningful practice makes him a highly respected voice in this field. During the lecture, if you have any questions, please feel free to put it on the chat and it will be answered at the end of the lecture. Please join me in welcoming Dr. Daniel Bronnert as he shares his knowledge and expertise on one of the most vital responsibilities we hold, keeping children safe. Over to you, Dan.
Thanks very much. Welcome, everyone. I've just shared my slides. Is that showing up?
Yes, Dan, yes.
Yes, Dan.
Excellent. So yeah, I'm going to talk to you all about child safeguarding. Obviously, this is a massive area. So I've tried to cut it down into a few sections, which are very useful for middle grade doctors. So we'll talk about safeguarding and child protection, what it is. We'll talk about recognizing abuse and forms of abuse. We'll then go on to talk about child protection medicals. This was an area I found very daunting when I was a junior doctor and writing child protection reports. Again, an area that's very daunting and you could take hours doing them. But once you get into them and get used to how it's done, it gets a lot easier, I can assure you. So yeah, safeguarding children. It's not a particularly popular subject, and lots of people find it quite scary. They find it unpleasant and palatable. They find it very time consuming. It has a bad press. There's legal ramifications. There's also the fear of missing something or making the wrong decision. But again, if you do it in the right way, you understand the signs you're looking for, you present a clear report that's unbiased. Again, you don't need to worry as much about these, and we'll talk about that today. So safeguarding versus child protection. Safeguarding's the broad concept. It encompasses all of the welfare of children, and there's lots of different areas to safeguarding. Child protection is a very focused area, and it focuses specifically on preventing abuse and neglect. Both are essential in ensuring children's safety and well-being, but safeguarding practices can help identify potential abuse and child protection issues. And collaboration amongst ourselves and amongst all professionals, including social care, health, needs to take place for effective safeguarding to take place. So working together defines safeguarding as everyone who works with children has a responsibility to keep them safe. No single practitioner can have a full picture of a child's needs and circumstances. And if children and families are to receive the right help at the right time, everyone who comes into contact with them has a role to play in identifying concerns, sharing information, and taking prompt action. So why is safeguarding important? Scarily, the World Health Organization estimates that 40,000 children die each year because of maltreatment. That's an enormous number. 1 in 10 children in the UK have suffered from neglect. 1 in 15 children in the UK have been emotionally abused. 1 in 14 children in the UK have been physically abused. 1 in 20 children in the UK have been sexually abused. And on average, at least 1 child is killed a week in the UK as a result of abuse. These are massive numbers, and we as frontline staff have to pick things up before it gets to this stage. Child abuse and maltreatment has a massive impact on children. It can have physical, mental, and we'll talk about physical and mental effects, which we'll talk about now. So physical injuries, obviously, if a child is hit or thrown or squeezed or strangled, it's going to potentially have a physical impact on the child, and that can lead to both disability and death. Head injuries can impact on children's development. It can impact on children's hearing and vision. Neglect can also have a massive impact on children. It can lead to developmental delay. It can make it hard for them to pick up expressive language. They can't do imaginative play, and it can impact on their growth. And this can lead to a massive long-term impact on children and society in general. It can lead to children, as they get older, taking on risky behaviors, such as smoking, drug use, alcohol use. It can lead to obesity, ischemic heart disease, and these are things that, again, if we can prevent, it will have a huge impact on society. Child abuse and maltreatment can also have significant psychological effects on children. It can have immediate effects and also long-term effects. Immediate effects, obviously, if you're being hit by someone, you're going to be fearful, you're not going to be able to trust people, and you'll feel isolated. Long-term, it can lead to depression, severe anxiety, panic attacks, post-traumatic stress disorder, and suicide. And that's why we need to sort child abuse out. Understanding children's experiences of abuse. There's lots of papers on this now. Children often feel fear, confusion when they've been abused. They often struggle to express their feelings verbally. And as we've just mentioned, it can lead to long-term emotional and psychological trauma. Children may exhibit behavioral changes as a result of the abuse, which can lead to them taking on risky behavior, going into the prison system, and again, that's something we need to stop. So what's expected of us as doctors? We have a responsibility to identify potential markers of abuse and pick them up. In patients under your care, you'll be seeing children on a daily basis, and if they have markers or possible markers of abuse, you need to be able to pick up on those and make sure that the child is safe. You need to act on honestly held and reasonable fears about a child's welfare. Confidentiality is not an issue when you're dealing with potential abuse. If you're worried about a child, you're worried that they've been abused, you need to speak up. You need to share information amongst social care, health, and education. And so we get a clear picture of what's going on in these children's lives. And we need to take appropriate action through appropriate channels by raising our concerns to social care and speak up about any concerns that you have. If you see a child in your day-to-day work, you think something's not quite right, speak up, speak to your seniors and raise it. Most hospitals will have child protection teams, and if you're worried or want to run something by them, we're happy to answer the phone and discuss cases. So we'll talk about the different forms of abuse. The main categories of abuse are physical abuse, emotional abuse, neglect, and sexual abuse. Physical abuse is where someone's hurts or harms a child or young person on purpose. It can include hitting, slapping, shaking, poisoning, burning, biting, drowning, and the signs of that are bruises, broken bones, bite marks, scars, and we'll talk about those a bit later. Sexual abuse. This is where a child is forced or tricked into sexual activities, both contact and non-contact, can happen in person or online, and signs, emotional and behavioral changes. Children can become avoidant or fearful. They can start using inappropriate language for their age or exhibit inappropriate behavior for their age. They can start self-harming. And then there's the physical signs of sexual abuse, which is bruising, bleeding, pain, early pregnancy, and sexually transmitted infections. Emotional abuse is abuse that involves continual emotional mistreatment of a child, like deliberately trying to scare them, humiliate them, isolate them, or ignore them. And this can lead to the child becoming unconfident, lacking self-assurance, struggling to control their emotions, having difficulty making or maintaining relationships, and acting in a way that's inappropriate for their age again. Neglect. Neglect is a massive area and can sometimes be quite hard to pick up on. There's four main types of neglect, and they're physical, which is failure to provide basic needs, educational neglect, which is preventing a child from getting a proper education, emotional neglect, the child doesn't get the nurture and stimulation they need, and that can be through ignoring the child, humiliating the child, intimidating the child, or isolating them. And then there's medical neglect, where the child isn't given the proper health care, for example, not turning up to appointments repeatedly, not giving the medication that the child's been prescribed. And also a big one that's getting bigger over the years is dental neglect. Getting an appointment at a dentist has become more difficult. And if you're missing those appointments, you'll get thrown off the list. And that can lead to dental caries and ongoing health issues as a result of the mouth. So let's talk about recognizing abuse. So when we're talking about recognizing abuse, we need to think about risk factors. Are there any risk factors in the background? Because they'll increase the risk of abuse. And then think about the indicators of abuse, which you'll get from taking a detailed history, examining the child, and also undertaking investigations. And when you're thinking about abuse, you need to think about all of those together, and that will give you a suspicion if there is one there. So risk factors for abuse. Child factors which can increase the risk of abuse. If a child has significant behavioral problems, for example, if they suffer with ADHD, they're constantly on the go, this can lead and increase the risk of abuse to the child. Children with complex medical or developmental problems, that can also lead to an increased risk of abuse. Male gender, and also young children and non-verbal children also increase the risk of abuse. Parental factors increasing the risk of abuse include poor education, substance misuse, mental illness, young parents, unintended pregnancies, and a history of abuse in parents can lead to perpetuation of the cycle and lead to the children then abusing their children, and it just going on. Family factors increasing the risk of abuse. If one of the parents is an unrelated caregiver, if there's low social economic status can increase the risk of abuse, single parents, and if there's a history of domestic violence, they're all important things to think about. Child abuse is often most frequently missed in the UK when parents are Caucasian, they're upper or middle class, and parents are married. We'll also talk quickly about hidden men or unseen partners. There's two main types of unseen partners, and that have been identified in case reviews. There's partners who pose a risk to a child, which have resulted in the child suffering serious harm or death. But there's also partners who are in the background who don't attend clinic or the hospital, who can protect and nurture the child, but have often been overlooked by professionals. So when taking histories, ask about who else is at home, who else is looking after the child, and have a think about those things. So let's go on to talk about some of the signs of abuse. I'm sure you'll have all seen a lot of these working, but we'll go through them anyway. So bruising, it can be the first sign of physical abuse. Remember, bruising can't be aged. You'll often be asked by people outside of health, for example, social care, so then doctor, when did this bruise happen? And don't give an answer. Bruising can't be accurately aged, and giving an answer can get you into a whole world of mess. I shan't use the other word. It's often a sentinel injury. Often if you've been hit, you'll develop a bruise, and that's the first sign of the injury. One thing to remember is if a child's been hit in the abdomen, or there's been blunt force trauma to the abdomen, often the abdomen, because it's quite squishy, doesn't bruise. And lack of abdominal bruising, sorry, let's skip to slide. Lack of abdominal bruising does not preclude a significant abdominal injury. So, pathogenesis of abusive bruises. We've talked about the risk factors for abuse. So, talking about bruises, history-wise, one of the big things is whether the history that you're being given is in keeping with what you're seeing on the child. A child who's fallen down the stairs and got multiple bruises could fit. If a child's just fallen out of the pram but got bruises to the front, back, head, and arms, that doesn't fit. And as soon as you've taken that sort of history, that should raise your concerns. Also, thinking about when you examine a child, the position of bruises. Those that don't cruise rarely bruise. Older children who are active, particularly toddlers, will bump into all sorts of things and they will get bruised, just do it through normal play. But the areas they get bruised on are areas over bony prominences like the knees, like the elbows. Soft tissue bruising is more of concern, and we'll talk about that shortly. Again, part of the safeguarding workup, if you're seeing multiple bruises, is to do a baseline clotting. If that's coming back abnormal, that raises concerns that this child's clotting is abnormal and that they could bruise more easily. Obviously, if the clotting is completely normal, again, the question arises, how has this child got this bruising? So yeah, bruising is commonly seen, as I've said, in toddlers and mobile children. Younger children, particularly those who aren't mobile, bruising on non-mobile children, particularly those less than 4 months, should ring alarm bells instantly. And if you're seeing bruising, you need to know exactly how it's happened. And a parent coming in and saying, oh, I don't know how that's happened, just doesn't fit. A 4-month-old and younger are going to be lying with the parent most of the time. If they're left on their own in the room, they're not going to be able to roll or jump out of their bed and therefore bruising in that age group should raise concerns. So accidental bruising, as I've said, is typically over the bony prominences. You can see it over the knees, lower legs. You can often see it over a T, over the forehead, going down the nose to the chin. And those are the areas that a child will often bump and hurt if they've run into something. You'll also see it over the spine. If they've fallen backwards and hurt themselves, they'll get the bruising over the bones, over the spine. Non-accidental bruising typically happens over soft tissue areas, for example, over the cheeks, around the eyes. Children don't typically bump their ears, and if you're seeing bruising over the ears, that raises concerns. Bruising to the genitals, to the abdomen, to the thighs, again, these aren't typical places that you bump or fall over and hurt. When you think about bruising, always think about the mechanism. And if the mechanism isn't fitting, again, that should raise concerns about whether this is accidental or not. When you're assessing bruising, always think, what is the developmental ability of this child? As I've already mentioned, and will do multiple times in this talk, those that don't cruise rarely bruise. Remember, always take a good developmental history when you're clerking a child with bruising, because you need to know what the child is capable of. You'll often have wide developmental differences between different children of different ages. You'll have some 1-year-olds that can run around. You'll have other 1-year-olds who are still only able to crawl. So make sure you take good developmental histories and think, could this child have got this bruise? Also think about where you're seeing the bruise, like we've just talked about. The number of bruises, increased number of bruises raises further concerns. And if there is a pattern to the bruise, that should raise concerns as well. For example, if a child's been hit by a belt, you can sometimes see a buckle mark. If they've been hit with something else like a shoe, you can sometimes see the tread mark within the bruise. This is a useful acronym which should, again, raise concerns to you about bruises. 10-4 faces P. So bruising to the torso, ears, neck. If there's bruising to the frenulum, angle of the jaw, cheeks, eyelids, or subconjunctivae. If the child's 4 months or younger, any bruise or anywhere. And patterned bruising, all of these should raise concerns that this could be an abusive bruise. So next we'll talk about fractures. This is another thing you'll see if you're working in an emergency department, children coming in with fractures. And again, working out whether these are abusive or not can sometimes be difficult, but you need to be alert to the potential ones and raise that to other people, discuss the case, and if there are concerns there, raise it to safeguarding teams. So fractures are the second most common injury caused by child physical abuse. In infants and toddlers, physical abuse is the cause of 12 to 20% of all fractures. No one fracture in isolation is specific for physical abuse, but there are specific fractures which are highly suggestive, and we'll talk about those shortly. Again, the key is the history and developmental stage of the child. You need to be able to visualize how that fracture occurred with the history you're presented with, and that it fits with the developmental age of a child. Remember that you're not alone. The experts on bony injuries are orthopedics and radiology. And if you have a clear history, run it by orthopedics and radiology, or set up an MDT meeting with them to discuss the injury if you have concerns, and then come to a consensus. Big things that should raise alarm bells are fractures in non-mobile children. Fractures in the under 2s are concerning, as often the child can't tell you what happened. It doesn't mean that they can't occur. Some 2-year-olds have no fear. They'll dive off a wall, things like that. But be sure you can visualize what's happened and that the child's development is in keeping with what you're seeing. Rib fractures, remember to look for these in all chest x-rays. Often a child with a rib fracture that happened a week ago won't have significant pain in the area, and the only way you'll pick it up is on chest x-ray. When we're looking for an infection, we need to also look down the ribs to look for any signs of rib fractures, because you may actually find some. And if you do, obviously that's a significant concern. So talking about abusive fractures, things that would increase the risk of abuse, we've talked about the risk factors already. If a child's extremity is twisted, you can often lead to a spiral fracture. A twisting of a child's extremity can still happen through normal play. If you're running, you stick your foot into a pothole and your leg twists, that can sometimes lead to a spiral fracture. But a 3-month-old with a spiral fracture of their arm, that's not going to fit. If a child's extremity is pulled hard, you can get a metaphyseal fracture or bucket handle fracture, and I'll show you a picture of one of those shortly. If a child's violently shaken, you may see associated brain bleeds on CT scans. Compression of a child's ribs, particularly posterior rib fractures, should ring alarm bells and raise significant concerns about abuse. And blunt force trauma can also lead to fractures, and spinous process fractures, sternal fractures, and scapular fractures are all concerning for potential abuse. This is a spinal fracture of a femur. You can see that the bone's twisted. This is obviously looking at the child. It's in a young baby. You need to have a clear picture of how this has happened. Rib fractures, you can see the rib fractures down at the right and left side of the chest on this chest x-ray. The sort of bulbous shape on the rib. I'm not sure if you can see my pointer. These going down, and these we should be looking for whenever we carry out a chest x-ray on a child. And again, rib fractures. Bucket handle, metaphyseal fractures, like I mentioned earlier, they have a high specificity for child abuse when they occur during the first year of life. They're caused by torsional and tractional shearing strains applied across the metaphysis, and typically occur with vigorous pulling or twisting of a child's extremity. Next, we'll talk about burns. This is another thing you'll see working in emergency departments, children coming in with burns, and you should always ask yourself, how has this happened? Does it fit? And could this be potentially abusive? So the main types of burns are immersion burn, where the extremity has been placed into a hot liquid. Contact burns, for example, if a child touches a hot iron, or if the child is intentionally hurt by someone, for example, with a cigarette end, that will cause a contact burn. And then scalds when hot liquid has fallen onto the child. So immersion burns, when a child sticks their hand in something hot, the first thing they're going to do is pull their hand out again. You need to think, is this history and development compatible with the injury? A child who is not able to climb up onto a surface is not going to stick their hand into the washing up bowl, but an older child who can reach over the top may well do that. They will typically they will pull away as a reflex, and that will lead to a non-uniform and quite irregular burn. If the history and development isn't compatible with the injury, or what you're seeing is not non-uniform and irregular, you need to think about, could this be a non-accidental immersion burn? Typically with non-accidental immersion burns, the child's extremity or the child themselves have been held in the water. What happens if you're pushed down into a very hot bath is your bottom will hit the surface of the bath, and as a result, the hot water doesn't get to it. And that leads to a donut pattern that you can sometimes see on buttocks. If a child's leg has been pushed into the hot water, again, the sole of the foot will hit the bottom, and the sole of the foot will be spared. If a child's thrown into a very hot bath or hot liquid, they will instantly curl up to help protect themselves, and that can lead to, when they're getting out, a zebra pattern forming as a result of the water not being able to reach these skin creases. If a child's limb is held still in hot water, you'll often see a very sharp border, and that creates what's known as a glove and stocking burn, where you get a very sharp border, for example, around the wrist, around the hand, that's clear, and clearly the child's hand must have been held in the water for a prolonged period of time. Well, not prolonged, but a period of time, and the child not being able to move the hand, leading to a clear and sharp demarcated border. So contact burns, accidental contact burn, again, if you touch something hot, you'll reflexively pull away. It'll be a brief contact. Again, the history and development will be compatible with the injury, and as I've mentioned, the child will pull away. Non-accidental burns, you tend to get a more uniform pattern because the object's been held in contact with the skin for a prolonged period of time. You'll often see these burns on non-exploratory surfaces. If a child's reaching up to touch something, they're going to reach palm of the hand first. They're not going to go up with the back of their hand or try and touch it with their elbow. And so you may see these types of burns on non-exploratory surfaces, and that should raise concerns. If there's cigarette burns, typically lead to a 5 to 7 millimeter sharp demarcated circle, and if you're seeing those sorts of burns on a child, that should raise significant concerns that the child has had a cigarette stubbed out on them or been burnt by the end of a cigarette. Other things that increase the risk of any injury really is a delay in presentation, particularly with burns if they're within the nappy area, if there's sharp borders, as I said, uniform depth, and if a child is repeatedly presenting with burns, that should raise alarm bells. Scalds. So scalds, again, if a child pulls something hot off the side onto themselves, the liquid will run down them and you'll get a flow pattern. The difficulty with scalds with regards to accidental and non-accidental is typically they both look the same. However, think about where the liquid is. A child isn't going to be able to pull liquid down onto their bottom from the side. It's more likely to have been poured over their bottom or over their back. If they have reached up and pulled something off the side, they may get splash marks over their face and drips down the front. And if they are a child that's tall enough to reach the side, mobile enough, developmentally able enough, then that could fit a scald burn to the face and front. Scalds can be quite difficult to determine whether these are accidental or non-accidental, and you should have a high degree of suspicion when you're reviewing a scald. We'll talk briefly about sexual abuse. Sexual abuse is a very specialist area, and this is not an area that I'm an expert on. In Leicester, all sexual abuse cases go to what we call SARC, the Sexual Abuse Referral Centre. They're a specialist centre that are trained to deal with sexual abuse, and as a result, we send our potential sexual abuse cases there. So signs that should raise potential concerns about sexual abuse, Emotional and behavioral signs. So if a child's avoiding being alone or frightened with specific people or a person they know, if they're using language or sexual behavior that you wouldn't expect them to know, that should raise concerns. Having nightmares, bedwetting, obviously with other things around them, could fit and you should make sure that the child is otherwise it's not happening. Alcohol and drug misuse can occur as a result of sexual abuse. Self-harm can occur as a result of sexual abuse. Children developing eating disorders can occur as a result of sexual abuse. Sexual abuse can lead to changes in a child's mood. The child can become very irritable or angry and act out of the ordinary. And changes in normal behavior. Obviously, these are very blanket things, and you'll see them with lots of other things. But if this is all happening, the child is speaks to someone, then it could all fit with a pattern. Physical signs, obviously bruising to the genitals, bleeding, discharge, pain and soreness in the genital area. If a child presents with a sexually transmitted infection, including sexually transmitted infections in the throat, pain and soreness, pregnancy, and if a child's having difficulty walking or sitting, that is again unusual for the child, this should raise concerns. But obviously you should be looking at all of these things as a whole. In Leicester, we're not trained to manage sexual abuse. If you work in a centre that is trained to manage sexual abuse, then things will be managed differently. But in Leicester, any suspected sexual abuse victims would be referred via social care to the Sexual Abuse Referral Centre. Following a disclosure regarding sexual abuse or if concerned about possible sexual abuse, we should speak to social care and don't undertake an internal genital examination unless acute medical treatment is required, as that can prevent useful samples being available when they go to SARC. So another massive area is neglect. Working together defines neglect as a persistent failure to meet a child's physical or psychological needs and likely to result in a serious impairment of the child's health or development. This can be quite tricky to bring together, and with neglect, you often have to look at large numbers of different areas, and I'll talk about a neglect toolkit that we use here in Leicester. Neglect is widely considered the most common form of abuse. It can present itself in a multitude of ways, including emotional, physical, educational, and medical. And children that suffer neglect are often subject to other forms of abuse. So if you're seeing a child with a fracture, with a bruise, think, is the child dressed well? Is the child getting to school, getting to medical appointments that they need to go to? And is the child clean and getting the food they need? So obviously, I think there's too many people to question, is this neglect? This is a child. Is there enough? Can people answer this, or is there going to be too many people?
You can put responses on the chat, guys. Everyone can put responses on the chat. I think we have yes, yes, yes.
Guy's a genius.
So what are people saying about NITs?
A lot of yes, yes.
A lot of yes. Well, my sons had NITs. And I had NITs when I was at school. So what would make it turn into neglect? So NITs itself can be picked up at any school. You often get outbreaks of NITs at school. You'll get a message home from the teacher saying, we've had an outbreak of NITs, please can you treat the whole family. When it becomes neglect is when, despite those warnings, the child repeatedly is having NITs, the family is not being treated, and it's repeating cycle. A one-off NITS diagnosis is not neglect. It's when it's repeated and the warnings that parents are given or the advice they're given or the treatment they're given isn't provided to the child, and as a result, it persists. So indicators of neglect: being smelly or dirty, being hungry or not given the money for food. That can be a difficult one. Lots of parents don't have the money to buy the food that they need. And you've got to think about the background and social. If parents are out spending loads of money on drugs and as a result not able to feed their family, if they're not using resources that are made available to them, then that's a significant concern. But some parents will try their hardest and simply don't have enough money there for food. So that's a debatable area, but you need to look into the background first. Having unwashed clothes, having the wrong clothing, such as coming in the winter in a pair of sandals, are concerns, and having frequent and untreated nappy rash in younger children should raise concerns about potential neglect. So health and developmental issue, things that can suggest neglect. So if a child has severe anemia, as we've mentioned, the dental side of things, and medical issues is a very wide term, but if the child is repeatedly missing medical appointments, not being vaccinated, if the child has significant health needs and are not presenting to all of their appointments, that should raise concerns. If they're not being given the correct medicines, again, with these things, you've got to remember that parents may not know, and you need to make it very clear to parents what medicines they need, when they need to have it. But if you're seeing a pattern that they just don't get it, despite everything that you've tried to get the parents to give the medications, that should raise concerns about neglect. If children are presenting with regular illnesses or infections, if children aren't developing normally and they aren't picking up language or social skills, that can raise concerns. If they're having repeated accidental injuries because parents are letting them walk around upstairs with the windows open and fall out of them. If there's skin issues such as sores, rashes, flea bites, scabies, ringworm, that should raise concerns about neglect. Children who are tired all the time because they're not told to go to bed, they're allowed to play on their computer all night and stay up and watch inappropriate films, that should raise concerns. Untreated injuries or weight and growth issues, both sides. So children who are very underweight and aren't putting on weight because they're not being fed, but also the other side, severely obese children whose parents have been warned about the risks of obesity, but keep on allowing their children to eat whatever they wish. That, again, is another form of neglect. So housing and family, things that would be signs and indicators of neglect. So living in an unsuitable home environment, such as having no heating. Again, that is a contentious area if you can't afford to put the heating on. Social care need to help you, but if you're not getting that help, then what do you do? But if you've got the money, but putting the money into your drugs, not turning the heating on as a result, again, that would raise concerns about neglect. Being left alone at home for long periods of time with no one else to look after you, again, with young children, that's a form of neglect. Taking on the role of carer for other family members, being expected to look after someone and missing out on your childhood, that is another form of neglect. So behavioural signs, becoming aggressive, being withdrawn, depressed or anxious, finding it hard to concentrate or take part in activities, missing school will be a big one, showing signs of self-harm, and using drugs and alcohol. These are quite broad terms, and you'll see these with different forms of abuse, but you need to put together the wider picture. And again, the neglect toolkit, which I'll mention shortly, will allow you to do that. So in Leicestershire and Rutland, we have something called the Neglect Toolkit, and I'll give you a link that you'll be able to access this from at the end of my talk this morning. This goes through lots of different areas, and you have to grade the child on the different areas to produce a mark which will raise concerns or not about neglect. That can be quite difficult when you're seeing a child in ED with 10 minutes to see them, and if you're worried about these children, raising concerns to the safeguarding team, raising concerns if they're under any follow-up, then that can be looked into further down the line. But I'll give you a link to our Leicester Safeguarding Handbook at the end of my talk, and you'll find the Neglect Toolkit in that. So we'll talk about a child who's come in, who states to you while you're cannulating her with mum out of the room that someone's hurt her and what to do. She also says that she doesn't want you to tell anyone and promise to keep a secret. So what do you do in these cases? Disclosures can be a hard area, and I'll talk about that now, but you need to be truthful with the child, and unfortunately, you can't promise to keep secrets. So if a child does try and disclose something to you, listen, don't display any shock or disbelief, and accept what you're saying, what you're being told without judgment, and take it seriously. Reassure the child, but only so far as being honest and reliable, and don't make promises you can't keep. Don't tell them everything's going to be all right now, because there's a good chance it's not going to be, and they'll lose faith in the medical profession as a result. You need to reassure the child that they haven't done anything wrong, and that you're taking them seriously, and tell the child that you are going to have to let people know what they've told you to try and make them safe. But the people that you're going to let know are only people whose job it is to help protect children. You need to acknowledge how difficult it must have been for them to talk to you, and also reassure them that it does take a lot to come out with these things. Some children won't want to speak about things. You should, if they seem to want to let you know something, but every time you try and ask them to tell you something, they won't speak, suggest, do you want to do it on paper? Give them paper, or do you want to, obviously it'll be hard if mum's outside the room, but if they're on the ward, offer to take them off the ward with a nurse with you and just say, should we go for a walk and see if we can talk about it there? Always obviously make sure you have a chaperone if you're doing that. So you need to listen quietly, carefully, and patiently. Don't assume anything. Don't speculate or jump to any conclusions. And don't investigate, interrogate, or decide whether the child's telling the truth or not. Leave that to the safeguarding team, to social care, and if necessary, to the police. Use open questions. Just ask them, tell me about it, what happened, and don't ask specific leading questions like, was it your dad that hit you? Because you may get an incorrect answer. Obviously, like I've mentioned, refer to the local safeguarding team or the senior doctor on call if you've ever had a child disclose something to you, and make sure that the child is safe. Don't use any questions that would imply the child is at fault. For example, why didn't you tell me this before? What were you doing there? Why didn't you stop it? As that may make the child not wish to speak to other members of the team, for example, social care and the police. So open questions, and just be as reassuring as you can to the child. Big ones from the disclosure point of view is making sure you make accurate notes, make some scribble records, but keep them and then write them up in as much detail as you can afterwards, and try and record the actual words that the child uses. If they're swearing or using slang, scribble that in the notes. So we all have a duty to respond. Don't leave it for someone else. If you have worries about a child, speak to social services and discuss child protection medical. You should always get social care's backing to perform a child protection medical. When I started training, often we would just go ahead and do a child protection medical, but that can put you in a bit of an awkward area if social care turns around and says, I don't think a child protection medical was actually necessary. So I would always speak to social care first, speak to the duty social worker, explain why you're worried, and then advise them that my plan would be to undertake a child protection medical. Would you agree with that? And most social workers will agree with that and go ahead, but then you've got the backing of both health and social care for the child protection medical to take place. And always be open and honest with parents. You need to be open with them, and we'll talk about that a bit later, but always be honest with them, explain why you've got the concerns, unless that's going to place the child at risk. So talking to parents can often be one of the most daunting parts about when you're raising concerns from the child protection point of view. But before you go in, plan the conversation, be open and honest with them, use basic language, and if you've got a leaflet, provide them with one. Explain that this is your statutory duty. You're not doing this to be nasty to the parents. You're doing this because you have to, and it is part of your job. You have a duty of care to the patient, which would be their son or daughter, and you therefore this has to take place. It's often useful to avoid words such as child protection or child abuse, and you should try words such as concerns, welfare, or duty of care. Always use open questions. I need to talk to you about the injury to your son or daughter's face. Can you tell me what happened? Rather than, oh, did a brick hit him in the face? Because that can give them ideas about what may have caused the injury or explanations that aren't true. Whenever there's a worry about any child or a child presents with an unusual injury, explain to the parents that we legally have to investigate and pass that information on to social care. So we're going to have a break now, and I will go on to continue speaking about child protection medicals after the break. Are there any questions anyone wants to ask me immediately before the break, or do we want to just go straight into it?
Thanks for the lecture, Dan. I can only see 2 questions that we've gotten so far, so I think maybe we can answer them.
Yeah.
So one of the first questions we got was, can you elaborate on how male gender is at a higher risk for abuse?
So male gender, statistically wise, male gender is at a higher risk of abuse. It's been found in a number of studies, typically male children. I could give you possible explanations for why, but statistically, male children are at higher risk.
Okay. The second one is torus or buckle fracture in a 2-year-old considered as abuse?
What, sorry? Buckle
Buckle
fracture.
fracture, yeah.
In a 2-year-old, again, it will depend on how it's occurred.
Okay.
Any fracture could potentially happen to any age child. Obviously, a 2-year-old who was with their parents, dived out of a window because the house was on fire, could get any sort of fracture. But if it's not fitting with the history that the parents are giving you, that should raise concerns.
Okay. One of the other questions is refusing vaccines considered a form of neglect as it is becoming more optional?
So if it's up against all of the other ones, it would be something I would ask, have you given your vaccines? If they have a clear reason for not giving them, then you need to respect that. But if they've said, oh no, I just haven't been bothered to pop along to the surgery, I've had 3 appointments now, but each appointment I couldn't be bothered, that should raise concerns. But parents do have the right to refuse vaccines. But again, building the bigger picture. And if they've repeatedly said they want their child to have the vaccine, but repeatedly not turned up to the appointments, that should raise concerns.
The next one is, based on evidence, what fractures are considered more due to NAI than accidents?
So bucket handle fractures are high risk. Spinal fractures, sternal fractures would raise concerns. But again, it is down to age of the child's developmental mobility, how their development, and again, although in the past, rotational fractures did raise significant concerns, now those concerns have dropped down with time and people seeing children getting fractures as a result of twisting the leg, for example, while running.
Next is, a teenager with background of eating disorder has self-harm cuts in her hand. Can that be considered as neglect?
So not if the teenager is doing them themselves, but the question would be, why are they self-harming? And why have they got the eating disorder? Is there anything in the background from the neglect point of view that could have led to them feeling extremely low and wanting to hurt themselves? If that's the case, then it could be associated with neglect, but the actually self-harming itself, you can't say that this is the parent's fault.
The last question we'll go through is, in case of sexual abuse referrals, should pediatrics or gynecology review the patient first? And they've just mentioned that has been challenging in their practice.
So certainly in Leicester, we wouldn't get gynecology to come and review the child. Any sexual abuse case would go to a regional centre who have specialist paediatricians who have been fully trained in examining children with potential sexual abuse. It can be very difficult over the country if you have a paediatric gynecologist who's trained in doing sexual abuse examinations, then it will depend on your area, but certainly in Leicester, all potential sexual abuse cases will go through the Sexual Abuse Referral Centre, and that's typically run by paediatricians with specialist training.
Lovely. I think we've covered most of the questions. If there's anything left over, I can give it to you at the next next lecture. So we'll go for a break for 5 minutes. So at 11:10 or 11:11, we should be able to start the next part of the lecture.
Grand.
Hi all. I think everyone's gotten a chance to grab some coffee and gets comfortable. If Dan, you're ready, shall we start with the next part?
Yep. So I'm going to talk quickly about child protection medicals. This isn't going to be an in-depth thing because everywhere will do it slightly differently, but it will give you a few theories to go on. Child protection medical, when I first became a registrar, petrified me because you often don't get amazing training on how to do it. And it's an area that you don't really come across that much as an SHO, as a junior doctor, until you hit the registrar grade. But I'll talk a little bit about it, and I'll also talk about writing good reports, and why they are definitely learning how to do good reports will pay dividends later on. Let me just, yep. So the purpose of the safeguarding medical is to diagnose any injury or harm to a child and initiate treatment, assess the overall health and development, document the findings, and provide a medical report at the end.
Sorry, Dan, are you sharing?
Have you not seen? Let me share again. So coming up now.
Yes, it's coming up now. Thank you.
I'll have to zoom through. Can you see the purpose of safeguarding
Yes.
medical?
Yeah, thank you.
Excellent. So yeah, so as I've said, it's to diagnose, assess, document, provide clarity, and also arrange follow-up if the child needs it. So top tips for child protection medical is having a gold standard history and examination. We have a safeguarding medical examination pack in Leicester, which again, you'll get access to in my handbook at the end of this talk. Obviously, everywhere will have their own handbooks, but if they don't, have a think about developing one for your site. When you go and take a child protection medical history, unless you've got everything written down in front of you and just questions you need to ask, you'll often forget parts, and then it becomes a nightmare having to repeatedly go back and try and get that information. If you have it all in one handbook that you use, you can make sure that you get a detailed history, detailed examination, have it all in one place, and then it makes writing the report at the end a lot easier. So whenever you're taking a history about an injury, think about who was there, who was with the patient, who is who, and who was saying what. So also think about what happened in detail. Ask the parent to describe in detail, step by step, what happened, what led up to the injury happening, what happened at the time of the injury, and also what happened afterwards. And think about, have there been any changes in the version of the history you're being given compared to when the child initially arrived, typically through ED or through a children's admissions unit? Has the history evolved or has it stayed the same throughout? Think about when and where the injury happened and what brought them to the emergency department now. And can you understand how the injury has occurred? Remember, always speak to the patient. Obviously, you can't do this in a child that can't talk yet, but if the child is old enough, try and speak to them without the parents on their own. Always use interpreters and accredited interpreters if you're doing a child protection medical. Always use chaperones and always take a full developmental history. So documentation, always use body maps when you're describing injuries. Obviously photos are very useful and I'll talk about those shortly, but always document any injuries on a body map. And if you're going to do a child protection medical and you don't have a set handbook, as it were, always make sure you've printed off body maps and take them in to document all skin findings. Always describe where the injury is, the shape of the injury, the size of the injury, and its colour, particularly when you're dealing with bruises. And it's always useful to document the explanation for each injury itself. So, for example, this was an example body map with a child who's come in with a scratch on the face and also a big bruise and swelling to the leg. These are the sort of things that I would document. And when you're doing the medical, always think, have I got the information I need to write a medical report? And can I reach a conclusion? Or is there any information missing that I need to go back and ask about? Obviously, you will often not have the radiology findings. You may not have the ophthalmology findings, but always think and always ask early rather than later on. So in the UK, under twos get automatic specific investigations. Over twos, they're condition specific investigations. Remember occult trauma, where no history is given, abusive head trauma, retinal hemorrhages, and be led by findings, patterns, and forces. So if you're undertaking investigations because the child is presented with bruising less than 2 years of age, if the child's less than 1, we'll do a skeletal survey, a CT head, and also get an ophthalmology review. If the child's between 1 and 2 years, we'll always do a skeletal survey. We'll consider a CT head, particularly if the child's got bruising to the face, you would do one, and you would get an ophthalmology review. Children over 2, you should still consider a skeletal survey. If a child's presented with multiple bruises, they're 2 years, 4 months, they can't tell you what's happened. Think about whether a skeletal survey is necessary or not. Another big one that's often forgotten is we need to do MRIs of the head and spine on day 2 to 5 if on the CT head you find an intracranial hemorrhage, parenchymal brain injury, or skull fracture, or if the child's showing ongoing neurological symptoms or signs. Remember emergency treatment, you're still there to treat the child. If the child has got a fracture, they need that fixing. If they've got significant bruising, they're going to need pain relief. Skeletal survey, one other thing I forgot to mention about skeletal survey actually, is a skeletal survey is not 2 skeletal surveys. A skeletal survey is not complete until you have follow-up imaging, which typically takes place on days 11 to 14. So always warn parents when they're consenting for a skeletal survey that this will involve the imaging that we're going to do today or tomorrow, but also follow-up imaging on day 11 to 14. And it's only after that follow-up imaging has taken place that the skeletal survey has been completed. And it has to take place before 28 days because otherwise it's then considered too late. Other investigations that we do with child protection medicals are hematological investigations, full blood count, clotting screen, extended clotting screen only in certain cases, and I'll touch on that shortly. Biochemistry, the recommended tests are USNEs, LFTs, bone profile, vitamin D and PTH. And think about urinalysis. Think about urine toxicology, urine dipstick to look for blood if there's been significant abdominal trauma, and microscopy. Remember, if you're sending a toxicology sample, to think about chain of evidence forms. This way, if the case you're dealing with goes to court, it can be clearly documented how the sample was taken and how it's got to the lab. We use laboratory chain of evidence forms in Leicester. And again, I think there is a copy of this in the handbook, so you can see what it actually involves. Essentially, you need to have a signature and a name next to the person taking the sample, the person taking the sample to the lab, who has received it at the lab, and then it goes on to the lab staff, and the senior lab personnel will also sign the form. A big area, and it was quite contentious when I was a registrar, is photographs. We can now take photographs on hospital devices quite easily. In Leicester, we have iPads, iPhones, which can be used to take pictures. They're often quite useful because you then get a clear picture of what you're seeing, but you need to remember that photos aren't perfect. They're often, if they're taken on a phone, not by specialist cameras, they cannot be suitable for evidence purposes in court sometimes. However, most courts will accept any evidence that you've got. If you're using a smartphone, these are some tips to get the best images, but obviously check with your hospital where you're working before you go taking photos, and never take photos on your own phone or device. Always use a plain background, turn the flash on, make sure that you're taking images perpendicular to them, otherwise they can look a strange shape or elongated. Never take on selfie mode. And another big one, certainly that I've seen over the years, is taking lots of pictures of bruising, but not actually knowing where on earth this bruising was down the line. So if you're taking photos of bruises or injuries, always take a step back, take a distance photo, and then take a closer up, so you know exactly where it is and can clearly show where it is later on. As I mentioned, with child protection medicals, chaperones are extremely important. And getting someone to join you, a junior doctor or a member of the nursing team, you should always have for a child protection medical. You shouldn't use student doctors or student nurses. And I personally, when I'm doing a child protection medical, will get my chaperone to read my notes and see if they agree with what I have documented. And if they do, I'll ask them to put their signature next to it. Remember that documentation is your communication to others and also yourself. Often, if a case goes to court, it's 2.5 years later, you'll barely remember it, and you've got to have that good documentation to recall the events. Like I've mentioned, you need to document all and each and all skin findings, particularly if numerous. I've had one case where I had 45 bruises that I had to describe. It took quite a while, but it makes it a lot easier down the line when you have those descriptions. Always measure it, use a tape measure, describe the colour and the shape, and an explanation, if they can give you one, for each and every mark. And we've already seen this slide, so I'll go through it. So some evidence to be aware of when you're doing child protection medicals is around bone profile and vitamin D. There's currently no scientific evidence to support that low vitamin D levels are a cause of unexplained fractures. So just be aware of that. I'll just let you read through that. And only think that rickets could be a potential cause if there is both radiological and biochemical evidence of rickets. Another big one, when I was a registrar, we would typically do extended clotting screens on almost any patient that presented with bruises. However, the British Society for Haematology Good Practice paper from a few years ago now has clearly stated that if first-line clotting tests are normal, the child has no personal or family history to suggest an inherited bleeding disorder, no further tests are necessary. Obviously, if they're not, then second-line tests may be necessary, but I'd always recommend discussing those with a member of the haematology team. Another big one that we're often not that good at is getting the voice of the child. It's probably the single most consistent failure in safeguarding work with children. We go in, we speak to the parents, and we ignore the child sat on the bed, and we can't do that. We need to speak to the child and preferably speak to the child alone. Obviously, you can't do that with children who can't speak. Older children, though, we should ask the parents to leave the room and just say, I need 5 minutes with your son or daughter. I'm going to have whoever your chaperone is with me. Obviously, if they get distressed, we'll bring you in immediately, but we need to try and have a quick chat to them alone. And if you're in there with the boy or girl and they don't want to speak to you, that's fine. Clearly document, I've tried to speak to the child alone. You don't want to get the child distressed. But also give them the opportunity, is there anything you want to write to me or write down if you don't want to speak about it? So this is what I've essentially just stated. And obviously, if the parent says, no, there is no way you're talking to my son or daughter alone, again, clearly document that and place that into your child protection report, because that raises concerns. And remember, doctor-patient confidentiality. Any child over the age of 16 is entitled to doctor-patient confidentiality, and the doctor isn't allowed to discuss anything the child talks to them with the parents or carers. But remember, if the child is at significant risk, you will need to potentially break that. Another thing is just listening to yourself. Often something just doesn't seem right. You can't put your finger on it, but when you're seeing a child, when you're taking a history, there's just something that's not adding up, doesn't seem right. Trust your gut instincts and do some more research into it. Don't brush it aside. Think about what's going on. What else can I ask to try and clarify this? Can I get someone else involved to come and speak to the family and speak to the child? Do we need any further imaging or investigations to try and get to the bottom of what's going on? Trust your gut. If you're not happy, raise that as an issue. Another big one is putting it on paper. So child protection reports, putting stuff on paper, again, can be very daunting when you're doing it for the first time. And again, if your where you're working doesn't have a clear pro forma for doing this, there is one in my handbook which you can use. The big one is getting used to writing summaries and opinions. The earlier you get used to doing these, the easier they'll become. And when you step up to being consultants, you'll be expected to do these for all child protection medicals. And if you've got the practice in earlier on, it will make things a lot easier for you as consultants. So the aim of a medical report is to communicate what you've seen with the child, the nature of their medical condition, and any injuries that you've seen. You need to give an opinion on the likelihood of whether an injury is the consequence of abuse or neglect, and that can be quite hard sometimes. You also need to provide a rationale for that opinion and often back it up with research that's available. You also need to provide advice as to whether you feel the child's at significant risk at the moment, whether the child needs ongoing care, and that needs to go into your report at the end. Poor reports can place children at risk. They can come back and haunt you, particularly if you have to go to court, and they can make you look foolish later on if your report is covered in mistakes, doesn't meet with your baseline notes, this will all be picked up in court. One big thing to remember when you're writing child protection medical reports is that the people reading them often don't have medical backgrounds. You need to avoid the use of medical jargon, and we're often quite poor at doing this, and explain findings in lay terms. For example, we will know what a depressed occipital bone fracture is, what a hematoma is, but someone who is non-medical will often not know this. And scalp ecchymosis, what on earth is that if you're not medical? So you need to think about what you're writing, the way you're writing it, to make it nice and easy to understand for any member of teams with no medical background, such as social care, such as health, and put it in an easy to understand way, such as this. When you're writing a report, they need to be factually correct. They need to be well reasoned. They need to have some evidence base to it. They need to be neatly presented, and you need to be unbiased. Obviously, there'll be times when you're seeing a child who's been severely abused where the unbiased side can be difficult because you just think this is disgraceful. But when you're sitting down to write your report, you need to try and be as unbiased as possible. If your report's correct, non-contradictory, shows clear reason, and is backed up by evidence, you're much less likely to be called to provide further evidence in court down the line. Your report should be an accurate representation of your consultation, your initial consultation with the child and parents, and should match your notes. Discrepancies will be picked up later on. I've had one case where the size of the bruises in the initial clarking were completely different to the size of the bruises in the actual presentation. You can't do that. You have to think, does this give a clear, accurate representation of the history I took initially? If you're making changes, make sure you clearly document those and record those. And if you're making changes to your report, do it as an addendum. Don't cut bits out if you're adding stuff on. For example, a month later, a test has come back. For example, a toxicology screen, add it as an addendum to your report. So again, using templates when dictating, there's a template in my handbook, and there's also an example of a report that you can have a read through to get an idea of the sort of information that you'll be putting in. Remember, when you're looking at injuries, describe them individually, the position, the size, the shape, the color, and your interpretation of them, and whether you feel it matches the explanation that has been given for them by the parents or child themselves. When you're doing a report, a child protection report, you always should be putting the investigation results in. Lots of people will just simply state blood's normal or radiology normal, no fractures. I personally will put the full set of results in an appendix at the back. Radiology reports, for example, CT heads and MRIs, if I was up in front of a court and asked to explain all of the findings on an MRI, there is no way I would be able to do it for most. So it's always good practice. It's the radiologist that's writing this report. You're taking bits out of it, but I would always state, please see full report in Appendix 1 or 2 or whichever it's in. That way, later on, if in the future someone wants someone to go through the MRI, they'll be calling the radiologist and not yourself. Again, ophthalmology as well, I will always state the name and grade of the ophthalmologist who's done the test. I will always document in the report whether photos have been taken and what they've been taken of. So if in the future anyone wants to see those, they can access them. When you're writing a report, the first few sections, obviously, you're taking a history, as you would do with any child presenting to the hospital. You're taking a past medical history, you're taking a drug history, vaccination history, you're taking a full developmental history, you're taking a social and family history, you're doing your full examination, and then you come to the summary. The summary should just be a brief summary of relevant information from your examination, your history, and your investigations. You can also incorporate relevant negative information into the summary, and you'll be able to see that in the handbook. The opinion is the most important part of the report, and it must be very carefully worded. You need to think about how you're wording your opinion, and often with the first few you're writing I would always get a colleague or a senior to review them. Obviously, a consultant will typically be signing your report, but I would go and discuss your opinion with them and ask them to go through it with you. Remember that no new information should appear in this section, and be sure that you present facts and considered opinions. Don't speculate. Information shouldn't be exaggerated to try and sway a decision one way or the other, and don't allow bias to influence your report, as I've mentioned before. Opinions should include some of these. There are quite a few things, but interpretation as to the nature of the story and the medical findings, interpretation of the results and investigations, the relationship between the story and the findings and results, the likelihood of the cause of the injury or child's condition, any potential sequelae that the child's going to potentially suffer, the evidence base on which the opinions are based, and recommended treatment or interventions, and also any limitations to the opinion that you're providing. You should remember that law tends to work with binary logic, and it can be useful to use a funnel approach when you're forming an opinion to a child protection medical report. Using the funnel approach, you should think of all of the potential diagnoses that could explain what you're seeing. And then you should go through each and every one and discuss why it's not that or why it is that. And I'll show you that on the next slide. So for example, Thomas, he's a 10-month-old. He's come in. The explanation given to the ED staff was that he fell out of his pushchair yesterday. And then you've done a child protection medical on him, and he apparently fell out of his pushchair today. He's had a past medical history of a tonsillectomy and adenoidectomy for obstructive sleep apnea, age 8, with no complications, and there's no past medical history of note. There's no family history of any bleeding disorders. His bloods have come back normal, and baseline clotting screen is normal. Developmentally, he's able to crawl and use a spoon. He's babbling, but there's no clear words. So, forming a conclusion using the funnel approach for this example patient, the range of the diagnoses, obviously I expect there's too many people, but what would the range of diagnoses be in this case? They're essentially accidental injury, non-accidental injury, and a clotting disorder. Can anyone tell me why clotting disorder can be ruled out in this case?
Because of normal clotting profile, no
Yep.
family history of bleeding disorders.
Yep, definitely. Anything else? Anything he's had done that you'd expect some could go in bleeding afterwards?
He had tonsillectomy and adenectomy, and
Yep.
that went without, like he mentioned, with a significant history of bleeding.
Definitely. So I would put that in my report. A clotting disorder can be ruled out as the FPC and baseline clotting studies are normal, no previous presentations of bleeding or bruising, no complications from the adenotonsillectomy, and no family history of any clotting disorders. So the remaining diagnoses in this case are accidental versus non-accidental injury. Thomas is only able to ambulate by crawling. There's a suspicious distribution of bruises, and you can reference the RCPCH systematic review or the RCPCH Child Protection Companion Handbook for that. The history provided doesn't account for the extent of the bruising seen, and there's also an inconsistency in the history being provided with when the child presented, it happened yesterday, and now it's happening today. I try to put in evidence where appropriate into my opinions and things to use. The RCPCH systematic reviews on bruising, fractures can be very useful. Also the Child Protection Companion. When you're putting together an opinion, you should comment in the terms of the likelihood. So that can include all of these sort of phrases. But if you're not happy to provide a opinion, or you don't think you can, state that. But I'll talk about that shortly. You've hopefully read that now. So this would be my opinion in Thomas's case. So Thomas is presented with a bruising to the right side of his face, around the right eye and to his forehead. He also has bruising to his upper arm, raises to his forehead. The range of diagnoses in this case is accidental injury, non-accidental injury, and an underlying clotting disorder. I'm excluding a clotting disorder as Thomas's clotting screen is normal. In addition, there's no family history of any bleeding problems, and there were no complications to his adenotonsillectomy aged 8 months. On the balance of probabilities, I feel non-accidental injury is more likely than an accidental injury for the following reasons. Thomas has multiple large bruises, which I do not feel are explained by a fall from a pram. The distribution of these bruises is not typical of those seen in accidental injury, and I will have referenced the systematic review there. While Thomas can ambulate by crawling, I would not expect these injuries to have occurred through normal play, and where there is also an inconsistent history as to how the bruises have occurred with changes in timing. Following this, I would put an impact statement into my report, and in Thomas's case, I would clearly state that I have concerns regarding Thomas's safety and that I have shared those with Leicester City Children's Social Care. There will, however, be cases where you can't make a clear opinion, and if that's the case, say so. It's perfectly reasonable to state unexplained bruising or unexplained bruising which could represent accidental or non-accidental injury. They are acceptable terms to use. Obviously, you should, if you're unsure, run it by a senior, get the senior's opinion, and the senior will be countersigning your reports until you're at consultant level. But if you're unsure and you can't make a clear opinion, say so. And don't be forced into making an opinion. This is an example of an opinion where we weren't able to make a clear diagnosis. You can have a read through that yourselves.
If you're happy, then I will put a screenshot of both opinions so people can
No, that's fine.
read. Thank you.
I'll continue. So the end section is just going to be on some do's and don'ts when you're writing your reports. These are a few do's and don'ts. So intentional and unintentional, avoid terms intentional and unintentional. We're not mind readers. We don't know what was going on at the time the injury occurred. So don't state that the injury is an intentional injury. because you simply don't know what the mindset of the person was at the time that the injury occurred. And we shouldn't speculate on that. Remember that a normal clotting screen does not mean normal clotting. Always state that this is a screen and this is not, the child's clotting is entirely normal, because there are multiple other tests that can take place. State that you've done a clotting screen and that has come back normal. Not that the child's clotting is entirely normal, because that can be quite easily picked up. Another big one that you'll be asked if you attend strategy meetings is, so then doctor, how much force was necessary to cause this bruise or cause this bony injury, and when did this bruise happen? And these are things that you should avoid, particularly in your opinions and in your child protection reports. And when you're talking to social care and other agencies in strategy meetings, be very careful about stating how much force is necessary to break bones. Another big one is pain. All people feel pain differently. Some children can hobble around with a broken leg, still putting some weight through the leg. Others will not be able to get up at all. And again, it's very difficult to clearly state how much pain a child would have been in, so try to avoid it. Specific learning from the Daniel Palka serious case review, a big one was plausible. Doctor's comments that mother's description of an injury was plausible appears to have been a major influence in the decision not to pursue Section 47 inquiries. And the findings of the serious case review was that it would have been more helpful if doctors had simply stated that both an accidental and non-accidental cause were possible. Another big one that I've mentioned is bias. An example of bias here, for example, a child that's missed 3 failed outpatient appointments, you need to put that into context. If they've kept 15 others, that's very different to missing all 3 and no others. So make sure you always put things that could lead to bias into context. Time and date, always use the same time and date format throughout reports and use 24-hour clocks. Never talk about a long time ago or a while ago, because no one knows what they mean. Another big one is using mum, mummy, dad, daddy. Don't do it. The mother, using the term the mother again is not courteous. Try, when you're taking your initial history, ask the parent, what's your name? And use the parent's name in your reports. If you don't have the parent's name, then use the child's name and then mother afterwards. But don't use mum, mummy, dad, daddy, because it doesn't look good on reports in the legal arena. Be careful about the use of family as well. Some people talk about a parent as the family. You need to be careful about what you're specifying family to be. And it's often better to specify exactly who you've been speaking to. And again, he and she, writing child protection reports, this is something you'll learn about, but being very careful starting sentences or using he and she in sentences when it can turn into actually meaning someone else. So be careful with he and she's, and it's often better, although it can become quite repetitive, play the name of the child or of the parent each time you talk or start a sentence. would be consistent. It's not would be, it is consistent using that term. And again, reflecting, don't use the term reflects. The shape of the bruise is consistent or is not consistent. Potential and possible. Potential non-accidental injury, it's not potential, it's possible. It means that possible means the diagnosis of NAI is possible. Potential means that it could happen at some time in the future. When ascribing cause, try to avoid the word from. This is the NHS England Safeguarding app. If you haven't got this on your phone, I'd recommend we'll put this up in the chat so people can access it and download it, but I'd recommend that you download this to your phones. And finally, this is the UHL Safeguarding Handbook. This is the handbook I put together for UHL. This again will give you lots of information. It will give you example reports and also it gives you the equipment we use for our child protection medicals here at UHL. And I'm happy for you to read that and look at that. Again, we can put this up in the chat for anybody who misses it.
Thank you.
Is there any questions? That's the end. It's a massive area which I've tried to cram into 2 hours, but it's a massive area, and yeah, if there's any questions, I'll answer them now or we can answer them later.
Hi, Dania. There are quite a few questions. So I'll start off with the one that's been asked the most. So the first question is, it's a two-part question. At what age can you speak with the patient without the parent? And the second part of the question is, if parents do not allow you to speak with the child in person, what would you do? Or what would your advice be?
So from what age, it's when a child will start speaking. You can always state to the parent, you can stand outside the room. We're lucky in Leicester, we have glass walls, so you can ask the parent to sit outside so that the child can still see them, but then they can't hear what the child's saying. But it's typically when a child will speak to you. Very young children will often not open up. You'll need to build a rapport with the child and then say to the child, I need to have a chat to you alone. Will you have a chat to me alone? Obviously, if a parent is refusing to allow you to speak to their child alone, you can't force them, but you need to document that clearly, and you should clearly state to social care when you have a strategy meeting regarding the patient, I did try and speak to the child alone, however, parents were not willing to allow me to do this. And if things are going down the child protection route, then often social care may be able to try and speak to the child alone themselves later on.
Another part of the question was can you speak with the child alone with a chaperone if the child has Gillick competency, or do you still need parents' consent?
So if the child is Gillick competent, you'll find it hard if a child says, go out, mum, and parents are refusing, you'll find it hard to get them to leave the room. But a child who's Gillick competent can definitely speak on their own and can also present healthcare services on their own. But getting a parent who is not willing to leave the room, if it's causing a lot of shouting, the parent's getting upset, then sometimes it's best to take a step back and see whether you can speak to the child alone later on.
The next question is it acceptable to take the child to examination room without the parents being present?
So I wouldn't examine a child without their parents being present, no. You definitely need a chaperone present when you're examining a child, and you're doing, typically with a child protection medical, you're doing a top to toe examination. Obviously it will be of the external genitalia, but you shouldn't be examining children without the parents there, and the parents will need to have given permission for the child protection medical to take place.
Next one. In the first part of your lecture, you mentioned that an experienced parent can be considered as a risk factor. How is that so?
An experienced parent. So I think I can recall the slide you're talking about. So if a parent is extremely intelligent and can look things up quickly, then there's the potential risk that they will be able to pull the wool over our eyes and do a quick internet search, for example, what is the most likely cause? If you've told them what fracture their child has got, please tell me likely cause of fracture and give you a story that fits. So you have to be careful of that side of things as well. Also, parents who are intelligent, if they are worried that if they have abused their child, they may start getting worried and start putting barriers up to you carrying out a child protection medical. They may start making complaints and make it increasingly difficult for the child protection medical to take place.
The next question is, why is MRI head and spine done only on day 2 to 5?
I honestly don't know that. I would have to ask a radiologist that question, but that's the current guidance is on day 2 to 5. I presume obviously younger children may potentially need a general anaesthetic or sedation, which if there has been a significant brain injury could be dangerous. Whether certain signs may not show up until day 2 to 5, I honestly don't know. I'd need to check that with a radiologist.
Next one is, why is skeletal survey done after 28 days?
It shouldn't be done after 28 days. As I mentioned, the skeletal survey, you have your initial imaging on day 1. You should have your follow-up imaging on day 11 to 15. The reason we do follow-up imaging on days 11 to 15 is that fractures such as rib fractures, when they're fresh, you don't have any callus formation, and therefore they can be extremely difficult to see. By days 11 to 14, you should start seeing signs of fractures as a result of callus formation if they're difficult to see. But after 28 days, the current recommendation is it's too late to do follow-up imaging, and it's recommended that you get it done between 11 and 14.
Lovely. The next question is, why is sickling test done?
Which test, sorry?
Sickling. I believe it's a sickle cell test that they're mentioning about.
Sickle cell test, you wouldn't typically do a blood form, you just do a full blood count. I
Okay.
can go to the test slide.
It's a question. Oh, let me just go back.
Let me just get to... Those are the current.
I think maybe they were talking about the
Obviously, if a child's presenting with limb pain, you should think about sickle cell, but those are the standard bloods.
It was a question might be linked with the slides of anemia as a form of neglect. So I think it was from before.
Ah, right.
Yeah, that's fine. The next one is, in case of fractures, is it necessary to get an ortho opinion for every fracture?
So it's not necessary to get a ortho opinion for every fracture. If you're used to dealing with fractures, you've got a senior ED team on, and they are happy that they don't have any concerns, then you won't necessarily have to get an ortho review at that time. Often the child will be brought back to fracture clinic. But if you're worried that this doesn't quite fit, I can't see how this has happened or how this child with their developmental ability has done this, then it will often be useful to run it by ortho and say to the orthopedic registrar consultant, I'm not sure whether this fracture could have been caused by what parents are telling me. Can you advise?
The next question, which is a two-part question. If there are multiple bruises on the same limb, is it necessary to describe each one of the bruises separately, or can it be written that there are X number of bruises on this limb?
No, I would always describe each bruise separately, measure each one, and ask the parents, so how do you think this has happened? If they say that all of the bruises happened in the same way, then it makes it a bit easier, but you'll often find with children, they will have multiple bruises that happen at different times, different days, and you should try and document all.
And I think you answered the second part. The second part of the question was, for each bruise, do you have to write your opinion about each one of them?
I would recommend that you do, yes. And certainly in my reports, I will always put an opinion next to each bruise as to whether I feel it meets what I'm being told or the developmental stage of the child. For example, multiple bruises down the front of the leg, on the shin, I will put the size of the bruise, unless I've been told anything differently. I would state that this is a bruise which is commonly seen in a mobile child of this age, and I do not have concerns about non-accidental injury.
The last question I have is, if parents refuse to consent for safeguarding, what shall I do as a registrar?
So if parents refuse to consent for a safeguarding medical, you can't put them through that, but you should raise it to social care. You should phone social care. You'll have already spoken to them, hopefully, and they'll have advised that they agree that a child protection medical is necessary, but you should phone social care, explain that the parents aren't willing to consent to the medical, and then they will take it higher. And if necessary, it will go through the courts in order to get consent.
Perfect. I think that's all the questions that I have. If there's anything else, guys, please feel free to put it on the chat, and then we can go through it at the end of the lectures as well. Thank you so much, Dan. It has been really insightful lecture, and it was highly informative, and I hope everyone's been able to pick Dan's brains. But yeah, that's everything. Thank you so much, Dan.
No problem.
Just a gentle reminder, Joe, that
Yes.
at the end we'll be having a friendly chat with everyone, along with the faculty. Dan, Habab, Nadia, and Nadeem. We'll have a quick chat about all your concerns and all the challenges that you have. You can ask our faculty as well. Yeah.
Lovely. I think we have almost a 30-minute break now, because we're well ahead of schedule.
Then I
I-
think 10 minutes. Or is it?
Yeah, we can say 15 minutes because we're keeping up with time, so people can go stretch your legs, drink something, drink a lot of water, and come back fresh. So 15 minutes. I think we should start at quarter past. 18 minutes past to be very precise.
Perfect.
Thank you.
You guys soon.
Super. So next is I have the pleasure of introducing Dr. Muhammed Nadeem. He's a dedicated, passionate healthcare professional currently serving as an SAS paediatrician at Leicester Royal. Alongside his clinical work, he's a core member of the British Islamic Medical Association, where he plays a lead role in one of the most impactful initiatives, the Lifesavers event. This is an annual community outreach program that brings life-saving skills like CPR and recovery position and how to respond to choking emergencies directly to the heart of our communities in our mosques. In today's session, Dr. Nadeem will be addressing the challenges around communication during safeguarding assessments and the approach to communicating with parents. So please let's join and welcome Dr. Nadeem.
Hello, can you hear me?
Yeah, we can hear you.
Yeah.
Brilliant. Thank you so much. Assalamu alaikum and hello to everyone. So first of all, I would like to thank the CLEAD, BSAPCH and all the volunteers. I think for my experience, I haven't come across such a lovely full day free event for children, safeguarding, and obviously you're doing for betterment of children. So well done to you. So I will start with about my introduction because I moved to UK about 20 years ago, and obviously, as an international medical graduate. So when I moved to UK, the children safeguarding, that was very new to me because in our country it was almost non-existence. So first time I come across safeguarding was during the PLAB 2. I think most of the international medical graduates, they have this journey, East London, Swami at that time, and you have to pass this PLAB 2. And then when I joined the training, during the handover time, I have seen like when there is a handover time and, the registrar is handing over and they say, oh, there's a safeguarding as well. And you can see a worry and, maybe, oh no, and like, raising eyebrows as well. So you would just start thinking like that is something quite bad that, you have to avoid. But as we know, as a pediatrician, we can't avoid that one. So it's always better to learn and improve how to do a safeguarding, how to do a better communication so that it's a good outcome for the children. And obviously, you can avoid any consequences as well. So next slide, please, Robin. So my talk is about approach to effective communication with parents and obviously with children in the children safeguarding. Next slide, please. So the points I will discuss is understanding of children safeguarding, building trust with parents, effective communication strategies, addressing sensitive topics with parents, collaborative problem solving, challenges faced by IMGs and strategies to overcome, because I think quite a few in this listening are IMGs as well, and some simple approach to children safeguarding as well. Thank you. Next one, please. So a bit about definition and importance of children safeguarding. So I think Dan has an excellent presentation and he briefly gone through the full children safeguarding. So the main aim of children safeguarding is the policies and the measures that is aimed to protect the children from any harm, abuse, or neglect. And the role of healthcare professionals is very, very important because we are the one who do have to do the child safeguarding medical and then highlight any issues and then obviously discuss with the social services and other agencies as well. And we all know that effective children safeguarding does promote children's health, safety, and overall development. So what are the key principles and policies? So the primary focus, as I mentioned, is protecting children from the safeguarding, from neglect and harms. So just trying to move the picture so that I can see. Yes. Just 1 second. And obviously that involves empower the children. As Dan mentioned, the voice of a child is very, very important, and to participate them in decision making for their lives, and all of which we are doing for the best interest of the child, because obviously there will be children who cannot speak for themselves, and obviously you have to make a decision that is for their best interest. And there are policies as well that is very, very crucial, because obviously you have to follow them to make sure that we are promoting children health. Next slide, please. So there are different role and different responsibilities of different stakeholders. The parents have a very, very important role because they are the primary care providers and they are advocate for their children well-being, and they are the one who provide them essential support and guidance. educators, obviously, the nurseries and the school and colleges are very, very important, because I think you will see that most quite a few of cases you get referred from these institutes as well, when they see, like, signs of abuse and refer to us. Social workers, obviously, once they have identified any safeguarding issues, then they do contact workers, who has a very, very important role as well to protect the children from harm. And obviously government agencies, who are the one who make all these policies and regulate them. Next slide, please. Robin, how to, because obviously on the right side, I can see this, all the members. So I just want to remove them so that I can see full slides. Does anyone know which button I need to press?
If you click, there's like an X at the top of the participants. You can close the participant.
Oh yeah, that's true. Yes, I see. Can you share, because oh yes.
Yep.
Okay, it's just 1 second. Sorry. X. Sorry, where is that? I can't see now. Oh, it's done now. Brilliant. Thank you. Okay, sorry. Let's start again. Okay, so we play very, very important role in the children safeguarding, because what our role is to identify any issues related to child safeguarding, sign of abuse and neglect, and we have to intervene timely manners, and it's very, very important for us to report them to relevant authorities like social services, children safeguarding. So the safeguarding process involves, so obviously we have to be familiar with the safeguarding policies, both local and national. So that's why it is very, very important that whenever you move to a trust, make sure that you are familiarized with the local policies as well as national policies as well. Next, please. So in communication, you have to build a trust with the parents. We always, obviously, when I started, you always think like whenever you take children's safeguarding history, then it's different to, like, what you do, like with any other, like, for example, cough and cold. So it shouldn't be like that, because we are not interrogating. It has to be like friendly atmosphere, very welcoming atmosphere, because you need to build a rapport with the family, with the parents, and with the child as well. You have to demonstrate empathy as well, because if you imagine that they are very worried parents who must be thinking something very worse going to happen with the child and with them as well. So make sure that it's very friendly atmosphere, you have empathy with them, and that does enhance the communication as well, because when the parents feel confident, comfortable and valued, then they are open to communication, and obviously, you can get a lot of information that will help in deciding, what's going to happen with the special case at that time. Next, please. So ensuring transparency and honesty is obviously, you have to be transparent, you have to be honest. So whenever you start any communication with the parents during safeguarding, be honest, tell them why are you there and what is the main agenda of this talk. Sometimes we are a bit reluctant to be honest, and honestly, like, you might think like, okay, if I say that, I have to involve social services, then they might become angry. But obviously you have to be very honest, because you are doing for betterment of the child, and you have to mention that, it's a policy and guidelines that you're following, and not blaming them. You have to keep parents informed. So what I have noticed from my experience is like, yes, you do do examination, you take a history, and then you go away, and then don't inform them as well, because you have to tell them what is the next step. Are we going to do any further investigation? When they're going to happen? And once that happen, then do keep informing them as well, because they feel valued as well, because they're part of this process and they're not left alone. And again, be honest with them. So maintaining, yes, that's fine. Next, please. So, we all talked about confidentiality and respect. So it's very, very important uh, to be confidential, but you have to be very mindful as well. And you have to be very clear in your communication that, yes, it will be confidential, but obviously, if it is to do with the child harm or their health, then you have to involve relevant authorities like social services, safeguarding team. So just don't blindly, promise the confidentiality, because obviously during your talk, you come across there are some issues that you have to highlight to, social services or safeguarding, and then you tell the parents that all the talk will be confidential, then, you lose that trust with the parents. And obviously, they won't listen to you, because as I said, you have told them that will be confidential, but obviously you have uh, told the other authorities. And you have to build a trust as well, especially when you are dealing with the sensitive information. Do it with the care as well, and just to build a trust with the parents and the caregiver as well. Encouraging openness. So, respecting confidential encourages openness in discussions. So obviously, when you are honest, when you are involving them with the discussions, then they open up. And, then it definitely improve the communication. You can get all the information from them as well. Next, please. So when I attended the course regarding communications, I was literally shocked to see this slide, because I always thought that it's all about communication is all about you speak basically, but obviously it's very, very clear that's only 7% your spoken words, and rest is your voice, your tone, and your body language. And that's why it's very, very important that whenever you meet the parents, think about what is your body language, what is your voice, what is your tone, and obviously it's only 7% your words that count in personal communication. Next, please. So active listening, I think we all come across this active listening. um, you know, it's always very, very important that you listen to the parents fully. Um, don't interrupt, just let them finish. And that will engage your communication with the parents and show interest. I know, most of the time it is out of hours, you're thinking of other children that you have to see as well, and you might be thinking about them as well, but you have to make sure that you are listening to them, you are showing interest to what are the concerns and thoughts as well, and confirm the understanding as well, because sometimes what happened that you think, I have given information and then you said, okay, that's all, I have done my duty, but make sure that you do confirm what they understood, because what you're trying to get across to them might be different what they understood. um I will give you example. I think that's a real story that I have come across. That was few years ago. There was a child, I think it was few months age, went to see a GP, and there was some communication barrier between the GP and the parents. So the GP told parents that if it was some seizures or some fit, and the GP saw the child was fine, and he told parents that if it happens again, then what you need to do, that you need to, we give advice like shake the child, make sure that is responding, and then take a video recording, and then go to emergency department. So that was message given by GP. But obviously he did not confirm what the parents understood. So a few days afterwards, the child had another fit, and dad what he did was he violently shook the baby, and mom was taking a video, and then they went to emergency department. And obviously, I don't need to tell you what happened there. They have to involve social services, and it was initially dealt as shaken baby syndrome basically. So it's very very important that you confirm what they understood, and and if they are not very clear, then clear it out. um Thoughtful responses, so respond thoughtfully is very very essential in active listening. um Allow parents to feel appreciated and respected as well, so respect their views and their communications. You don't need to agree with whatever they say, but respect it, and obviously ask them as well. Next please. So addressing sensitive topics with parents. So it's not always that, like, you get along with the communications very well. There will be cases when, like, for whatever reason, the communication does not go well, and then there is a bit of angry parents, or, like, they are not happy with the situations. So you have to make sure that you are calm. Don't engage yourself in that difficult conversation. It means, like, just don't argue a lot. Use sportive language. Try to ease the tension with openness, and ask what is their concerns. Create a comfort as well, and obviously, if you think that it's not going to solve, then de-escalate. Dot just tell the parents that unfortunately, like, we are not agreeing on something, and I will come back in 5 minutes. Then let them some time to come down as well, go and come back in 5 minutes. And obviously, if you think that they don't have a trust on you, then you can involve your seniors and other people around you as well. Next please. So calibrating problem solving. So again, as I said before, that involve parents in decision making, empower them in decision making. Tell them, agree on some common grounds. As I said before, you don't need to agree on whatever they say, but obviously, if it is for the betterment of child, then that's what you need to agree on both. And you have to strengthen the partnership as well. And because all we doing is for the better outcome for the child. um, and involve parents enhancing overall all safeguarding efforts. And obviously, make sure that child best interest are prioritized. Next please. So it's very very important that you develop action plans together, um, among parents and caregivers, and obviously make sure that everyone's voice is heard, including the children. Obviously, if the children are very very young, then it's the parents. Investment in solutions. So when parents are involved in developing action plans, they become more invested in the proposed solutions and the effectiveness. Obviously, they know that, like, they are part of this decision making, and they are not left alone. um, and it is a shared responsibility in action plan that is committed to safeguarding children and promotes a supportive environment. Next please. So in conclusions, it's very very important, effective communication with the parents, um, to foster trust and understanding, and it's crucial for children safeguarding, and different strategies that you can implement between parents and professionals for better child safeguarding, and ultimately it is for the benefit of the child. Next please. So, as quite a few of attendees are international medical graduates, so I will just talk about the different challenges faced during the different safeguarding settings. Next, please. So I think when I moved to UK, so the one thing I found very challenging was the cultural differences. I will talk about in next slide, and it's very, very important that you do understand what is that, and you do try to find a way to overcome that one. And you have to understand the child behaving norms, because obviously it varies from community to community, and obviously a better communication as well. That is very, very important, because obviously for myself, for example, that was not my first language. So obviously, I had a lot of challenges as well, and you have to improve that one as well, as you go along. Next, please. So what are the key cultural differences? So I think the first part is very, very important, because obviously the place where I come from, it's the doctor patient and even doctor to doctor relationship as well, because I'm coming from a society where we are calling our seniors madam, and I never even imagine sitting with my consultant or head of service there and having a cup of tea. And when obviously I came to UK here and just found that everyone is calling by their names, and I was like, I mean, how is it possible? They are your seniors and they are your head of service, and you're calling them by name. And obviously they were having even with the juniors having a cup of tea and love. So obviously these are things you have to adapt very, very quickly as well, because obviously then you can open up with them and you can discuss any challenging you are facing with them as well, and that will help your communication skills as well. Healthcare team dynamics as well. Obviously here in UK it's mainly very multidisciplinary involvement. There are many other specialty involved as well, but it might be not the case from where you're coming. There are cultural differences as well. There are different traditional remedies, dietary restrictions in different communities and religion. There are spiritual beliefs as well that you have to think about. So what are the challenges? So there are obviously language barriers, different accent. There's a lack of familiarity with the system, and obviously if you are if you don't overcome these challenges, then you are left isolated because you don't want to involve, and there are issues with discrimination and prejudice as well. Next, please. So this is just couple of minutes video. So Robin, thank you, please. If you can just open that one. So this is about different accent that you can come across when you are coming, to UK. So just insight. No voice there, Robin.
Oh, is there no voice coming through?
No, is it muted?
No, the sound's working.
We got a wee bit of wind and rain here coming in from Glasgow going into Edinburgh. I know that sounds like a question, but it is a statement. And in Belfast, sit down right now, I'm going to fucking smack your head in because there's thunder and lightning, so get under the table. But in Dublin, everything's fine, so it is. There's beautiful heavy rain coming in for you, and it's going to look that way the whole year round. And in Cardiff, well, there's no weather today. There's just a giant marauding dragon. He's picking up the sheep in the valleys, cooking them up like a puppy pig. And in Bristol, well, the sun's out, which means wandering hands. I told him to keep his hands to himself. He said, "You're right, my lover." I said, "I'll tell you if you're my lover." And in Liverpool, there's a thing, what's it called? It's like a chicken, but with lips. What's it called? It's like a chicken, but it's got lips. Like, yeah, got lips. Oh, it's a duck. Yeah, duck. Yeah, there's going to be loads of ducks. And in York, go up to the pub and stay out to rain, because winter is coming. Pop in the kettle and make us a brew. And in Newcastle, going down the town late after the Raji storm, it'll be a proper clear night. You might see stars, you might even see Cheryl Cole, a repeat. And in London, "You're right, yeah, I'm alright, don't express my feelings, it's cloudy. My dad might be in the closet, but I'm alright." And in South West London, where people sound like they're on BBC Radio 4 and everyone's on Valium, Yes, the weather stays pretty much the same, you know, can't really complain, you know, things are going pretty well, yeah. And that's all we have for the weather. We got a wee bit of wind.
Thank you, Robin. Yes, if you see, I think it's very, very important as well when, especially the one who are planning to come to UK or very new here and obviously want to join a specific region. So you have to learn where are you going because, like, as you have seen in the video as well, they are different accent as well. I mean, even, staying in UK for 20 years, I, still struggle, especially if like you go across to Scotland because the accent is very, very different. So it's very, very important to know just not about UK, but also about where are you going and what are the accent there and any other cultural differences there as well. So what are the solutions? Obviously, there are culture sensitivity training, mentorship. I think it wasn't the case when I came 20 years ago, but now you can in almost all the local hospitals there are groups where mentorship is provided, and you can get a lot of sport. There are many language sport as well. You can build social connection as well, and obviously when you start working, then please, like, don't be isolated. Get engaged with the staff, especially with the nurses, because they are very, very good. They know the different norm, like other stuff as well. And I learned a lot from them as well. And do open communication. So by acknowledging and addressing these culture differences, healthcare organization can create a more welcoming and supportive environment for IMGs that enables them to thrive and contribute to the healthcare system. Next, please. So language barrier and communication skills. So obviously, impact of language barriers. So it can hinder effective communication, particularly in critical safeguarding situations, and obviously, it affect clarity and understanding that can have a bad outcome both for the children and for yourself as well. Medical terminology challenges, obviously for IMGs, they are often face the medical terminology difficulties as well, and again which can lead to misunderstanding in patients care and treatment as well. And it's very, very important that you develop language skills to improve your communication and seek support. That's very, very important, because if you're not sure, ask your seniors or colleagues, seek around if any group available that will help you to develop these skills, please. Next, please. So what is the impact of unfamiliarity with local safeguarding policies? I think Dan has mentioned about that one as well, because as you can imagine that, if you're not familiar with the local policies, then it can affect badly on child protection, child safety as well. And it's very, very important that you uh, do look for the local policies and national policies, and where you're working, just go through the policies so that you're not missing anything. um, and effective child safeguarding policies rely on comprehensive knowledge of local policies and procedures. So go through these policies, please. Just read them again and again. Keep a copy with you so that, whenever you have free time, you just go through them. Next, please. So what is the impact of communications issues? So risk of child safety and well-being. So poor communication, obviously, if the communication is not very good, and this child, you think that the story given is absolutely fine, but there was an issue with communications, then it might harm the child, because it could be like safeguarding issues. And that is why it's very, very important that effective communication, so that we can address potential risks to the children. And children safeguarding require vigilance and proactive communication to ensure their well-being. Next, please. And not only like for the for them, but also it can have a potential legal and professional consequences, um, like legal, including lawsuits and disciplinary actions from regulatory bodies. and failure to safeguard a patient can lead to loss of license and professional reputation as well. And obviously, it can impact career opportunities as well. And that's very, very important that you do, follow the local policies and adhere to them, and ask your colleague, your seniors, if you're not sure. Next, please. So how you can overcome challenges, especially for IMGs? So there are different sports available in local communities. Um, get that sport, and make sure that you are very clear in your communication, and make sure that you feel that the families understand and they are supported, and make a build a trust, as I mentioned before as well, because that is very, very important. Because if there's a trust between you and parents, then you can get all the information. There's a good rapport as well between you and the family, so that will definitely help in getting along with the parents as well. Next, please, Sobin. So again, as I mentioned before, do familiarize with the local safeguarding protocols, and because it does enables healthcare professionals to respond promptly and appropriately to safeguarding concerns. Next, please. Um, so it's very, very important that Dan mentioned as well. There are many previous unfortunate cases that does harm the children, like baby P, child Q. So please do read the outcome of these cases, because that's again something I learned when I came to UK, the importance of reflection. So please do reflect on that, so that you can improve, and and you can improve the future responses as well. So it's all your learning process, isn't it? Because obviously learning does not finish at some point. You can't say I know everything. So continue to engage with continuous learning, do involve in the training and resources. And they are, as I said, it wasn't the case 20 odd years ago, but now there are many sport groups available for international medical graduates, local and national as well. Do participate, and obviously, and it will definitely improve your communication skills. Next, please. So what is the key to effective communication? Active listening, ask questions, non-verbal communication. As I mentioned, that the verbal is like only 7%. Be clear and consistent. Be empathetic. Remain calm and positive. Seek solution together. Regular training. Voice of a child. That I will come across. So just a few slides on simple approach, just so if you see, whenever you do a child protection medical, then it's very tense for both the families and for you as well. Next, please. So just imagine, for parents, they are thinking that the child is taken away from them. So that is their first thinking, because whenever you mention that is the children safeguarding social services, that's what they're thinking. I will tell you a recent story I have come across. There was a child with special needs, very well known to myself, who was in one of the other ward. So I went to see the mom, because I know this child from when she was little one. So when I went to see mom, and she was crying, and I asked what happened, and she said they're going to take away my child. I said, I mean, what? How is possible? Because you're very, very caring. And then she said, the nurses had told me that they have contacted children safeguarding, and obviously that was the only message giving to them, but obviously they was not very clear. And for most of the parents, they must be thinking that when you involve safeguarding, it means that they will take the child away. Obviously, when I went to speak to the nurses, and they told me that it was not the case, it was just because she needs some support. So obviously then I came back and I just told her. So that's the parents are thinking, because they're thinking that something going to bad happen. They're thinking about police, isn't it? Because they might be thinking something bad we did, and then they will contact the police, and then they will come and have a chat with us. it is a mental stress for them because they might be waiting for hours and they don't know what's going to happen. And they are worried about future implication as well because they might have other children as well. Next slide, please. And for trainee, it is time consuming, isn't it? Because I think, and you are worried about other children in the ward as well, because like, as I said before, most of the time it is out of hours, and it's out of hour, and you are thinking about other children because you have to deal with them. You're worried about reaction of parents as well. You might thinking of it might go to the court, and sometimes you're not familiar with the situation as well, and that can make it a bit more difficult as well. Next, please. So how to approach? So get familiar with local safeguarding paperwork. Make sure that's a quiet place. If possible, please hand over your phone and bleep to the colleague, and get the information from the staff before you approach, because like, you can get, information as well. But obviously the main is the communication with the parents. Next, please. So during conversation, be polite. As I said before, we are not interrogating. We're just taking a history. Just listen to the parents, listen to the child. And it's very, very important to get an interpreter if language issues, because in children safeguarding you can't use the relative or staff. You have to get a professional interpreter, ideally face to face, but obviously it's not possible then over the phone as well. So don't just take a history if there's an issue with the communication, because then you don't know what exactly the parents are saying. Be honest, tell them, and and I have seen that one, like, just tell them, don't make any promises, just say like, yes, we have done this one. I have to contact the social services. We have to do this, bloods, say, skeletal survey, and don't promise that it's going to happen tomorrow and then they will be meeting and then, we will have a plan. So just say that these things we have to do. We don't know when it's going to happen, because first communication is very, very important. And if that is done properly, then normally there won't be any issues afterwards. And please clearly mention your plan and tell the parents as well, that is my plan, and document and answer any question at the end. Next, please. So I know you might be a bit tired now, but please, all of you, watch this 4 minutes video, and this video is my take home message. So if you don't remember anything and remember this video, that I will think that you got the message.
Article 12 of the United Nations Convention on the Rights of the Child states, I have the right to be listened to and taken seriously.
Listening is not just hearing, but also understanding what someone is saying.
When I cry, I'm talking to you.
When I fall silent, I'm talking to you.
When I'm naughty, I'm talking to you.
When I don't do my homework, I'm talking to you.
When I laugh, I'm talking to you. But are you listening?
It's your legal responsibility to listen to me so that my voice matters. It gives me a chance to express what I'm thinking and how I feel.
But it's not just your job to listen and to act on what you hear. It's my right to be heard, and it's also your job to explain that to me.
What's stopping you from listening is the excuses that you're too busy. It's the idea that my voice holds less validity than yours, because you're the adult. It's not my fault if listening to me and working with me to help me understand what's happening slows things down for you.
The consequences of not listening are not just causing me to lose confidence in my own voice. Not listening leaves me vulnerable.
I might hurt myself or run away because I'm scared.
What if I get into danger because you didn't take time to listen to something that you should have?
I listen to others to show that as one person to another, they have my respect and that I care about what they have to say.
I believe that the best way to be listened to is to listen to other people.
When I'm not listened to, it makes me feel insignificant. It gives me the impression that my voice doesn't matter and that I have no role to play in the future of my own life.
Give me time to open up and share with you.
Sometimes my voice needs influence. Help me with this.
When you find new ways to hear, you hear new things.
Give me an opportunity to share my voice with others, and when I can't, share my voice for me. If I can't talk or choose not to, then you legally become my advocate.
Listening to other people opens up my perspective.
Regardless of whether we agree or disagree.
I feel like I've helped them to know what they say counts.
When I feel listened to, I feel respected and I feel cared for.
It helps me to trust you with what I say and helps us work together. Show respect for each other, create a safe space to talk and listen where you and I feel equal.
I may be young, but we can stand shoulder to shoulder.
Ask me what I want. I need your support and someone to help me fight my corner.
Tell me what your decision will be before you go ahead with it.
Explain how this affects my life and tell me how the things I've shared helped you make this decision.
Don't keep secrets from me. It's my life you're talking about. I might not understand everything yet, but I'm the one living it.
Super, thank you, Nadeem. That was a really great lecture and focuses on a lot of the challenges that we come across. We have one question for you.
Yeah.
So how can you de-escalate a situation if you discuss social services to a parent and they become upset and aggressive, especially patients who do not speak English as their first language and you're using language line?
Yes, I think first of all, as I said before, if their language is not English, first language is not English, then you have to make sure that you got interpreter. You have to say the same thing that you are not doing this to blame them. You are doing this because that's what we are. As that's what our guidelines says or law tell us, and you are doing this betterment of this child. Just be calm. uh, Tell them like we are doing, obviously just tell them like you are worried about this child and we are worried about child as well, and we have to do what's the best for this child. And and obviously just stay calm. Try to answer their concerns, and most of the time they would listen to you. And because sometimes they feel like if they are some non-English background, like they're doing because of their color, but just say that this is what we have to follow, and it is irrespective of the color, language, or whatever.
Super, thank you so much. So I don't think there's any further questions in the chat, but we obviously have a session at the end of the day where everyone can have a talk.
There is one question that we can get as a last question.
Yeah.
What would be your opinion statement when a child with severe safeguarding and removed parents with a new safeguarding concerns, and parents are very defensive and concerned to start with thinking the child would be removed again? Let me rephrase this. Yeah, you can. Yeah.
Say it again, sorry, I didn't get it.
Yeah, okay. A child with severe safeguarding and removed parents, obviously, yeah, it looks like came back or something, with new safeguarding concerns again, and parents are very defensive and concerned the child would be removed again, like it was a second
Okay.
time.
So there was a previous issues with the safeguarding. Now came with, I think obviously, you are doing for the betterment of child, isn't it? So obviously, you have to take their concerns, but you have to do what's best for this child. And again, you have to explain then we are doing for this child. We are just following the policies and guidelines, and we have to do this one. Uh, you know, yes, they might become angry, and you might be worried they become angry, but think about the child. And that's why I think the last video was very, very important, because you're doing this for this child. And obviously if they are concerns about this child safety, then you have to involve all the body, all the safeguarding team as well.
Yeah, that's brilliant. I think you have already answered almost all the questions in our minds, so thank you so much for this session. Thanks. Okay, so guys, we have about 24 minutes break now for lunch. We will be back at 1:30 sharp, so please be on time. Thank you so much. Enjoy your lunch.
Thank you, Sama. Please, guys, do not miss the next session. It will be about the talk. The talk will be about the codes and the child death and the safeguarding around those areas. So it's very important for all of us. Yeah. Stay tuned.
Very challenging topic. Thank you.
Hello, everyone. I hope we're all back from our break. I hope we've been able to eat something, drink something, relax a bit. Thank you for staying with us as we continue today's safeguarding teaching program. It's a real privilege to introduce our next speaker, Dr. Nadia Baasher. She's a consultant in pediatric emergency medicine based in London and the co-founder of Team Soft Landing, which is an initiative that serves as the national hub for international medical graduates pediatricians in the UK and offers support, guidance, and mentorship. Dr. Baasher brings a wealth of experience and compassion to her work. And today she'll be guiding us through one of the most difficult areas of safeguarding practice, the topic of child death. Her insights will help us reflect not only on clinical responsibilities, but also on the emotional and ethical challenges we face in these tragic circumstances. Dr. Baasher, thank you so much for being with us today. Over to you now.
Thank you so much for inviting me today. It's a pleasure to come and present. My name is Nadia. As was mentioned, I'm a PEM consultant working at BHRUT in London. Just before we start, if I could ask you to go to menti.com and if you could enter, I'll just share my screen. Right, can you see my screen? Okay, you able to share the code? So if everyone can just go to menti.com just to get an idea of the audience and what your previous understanding about child death is before we go into the talk. So when you get to Menti, it will ask for a code. I'll put the code in the chat. So if you enter this code, just 4 questions. Perfect. So the first question is, have you been involved in child death in the UK? I'll give time for people to answer. Involvement means even if you're involved clinically, if you're part of the resource team, if you're part of the death review, whatever involvement have you experienced, as it were, child death in the UK? Obviously, abroad, in wherever else you work, you probably would have experienced it much more. But it's good to just get an idea of the Okay. So a lot of you haven't. I don't know whether that's because you are not working in the UK or because you thankfully haven't had any child death where you're working. Okay, I'll move on to the next question. Have you participated in a child death review? So a good number of you have, so you have a broad understanding. It's quite confusing when you start first to understand how these processes work. All right, and then do you have any sort of understanding, or have you read about it, or have, yeah, somewhat no experience? Okay. So as expected, the experience is sort of, people have somewhat understanding, and that's because we don't, thankfully, it's not something we do every day. And the purpose of this is to get a better understanding of what the process is. And I'll send the presentation and you can keep it for, and what do you aim to get from this session today? Understand the process. Sounds good. Understand confidence. That sounds good. Better understanding. Great. Some great answers there. So I'll stop the Menti and I'll share again. I will share my screen. I'll get my presentation. Can you see my presentation? Somebody just give me a thumbs up or a wave or anything.
Yes, we can.
You can. Great. Okay. I'll just take it back to the beginning. You can see that I'm very organized, can't you? You all get that vibe. I'm a very organized person. Okay, here we go. So when a child dies, so basically, thankfully, we don't have to deal with this every day. It's a big worry for a lot of people. Obviously, there's lots of components to child death, and it's a massive talk. You would probably need a whole day for it. I'm just going to go a quick overview of the basics, what you need to know in the acute settings, and how to support your team. So the outline of the talk is a few definitions, because you'll hear lots of things. You'll hear the nursing team, or you'll get emails if you've been involved with a child death from various agencies, and you'll hear like lots of jargon, like the JAR, the CDOP, and you'll be like, what are all these? So just before we start, we'll discuss some of the definitions, a few statistics on child death in the UK. Then we will go through the process, starting with your role in the acute setting. And then we'll move on to the ongoing investigation once the acute period is over, and then supporting bereaved families, and then looking after yourself and looking after the team. So we'll start with some definitions. So CDOP, what is a CDOP? Has anyone heard in the chat? Just give me a thumbs up if anyone heard the term CDOP before. So a CDOP is an independent multi-agency panel which are appointed to review all death resident in the local area. And the CDOP is usually composed of senior pediatricians, it's a multi-agency, so you'd have representative from social care, you'd have representation from community midwives, you'd have representation from the local authority, and it's usually the responsibility of the integrated care bodies or the ICBs to appoint the CDOP panel, who will review a certain number of child deaths per year. There had been some changes in 2018, which I will talk about later in our talk, and when sort of some reform happened and things were regulated and much better. When does this panel happen? The CDOP should happen within a year of the death, usually. Sometimes it can take longer depending on the circumstance. So a child death review meeting, so you'll hear lots of terms. So it's a CDOP, a CDRM, a JAR, you'll hear lots of different terms. So a child death review meeting is a local multi-agency panel review meeting where all matters related to the individual death are discussed to understand the circumstances surrounding the death and then to identify learning. So this is a local panel, which would be, this usually needs to happen within weeks to months of the death. A JAR is a joint agency response, and this is a urgent, as it were, meeting. It's a multi-agency panel review, which needs to happen within sort of 48 hours, ideally, of the child death. And this is in cases of unexpected child death. Okay, so all child death have a CDRM meeting. All child death will go to CDOP. However, a JAR will happen in cases of unexpected child death. And what's a designated doctor for child death is often a senior pediatrician appointed by the CDR partners, like the ICB, who will lead in coordinating responses and health input to that in that specific local area. So it's a designated doctor who will be responsible for all the deaths in any given region or area. Okay, so just looking at some statistics, so 60% of deaths in the UK happen in less than the first year of life, so in infancy. And the majority of those, as we can see, about 70% in the neonatal period, and a lot of those are related to prematurity or other complications, congenital anomalies, other factors, malignancy, SUDIC, chronic medical and surgical conditions, infections, and trauma. So I'm going to share some data from the National Child Morbidity and Mortality database. So looking at death so the majority of deaths you can see in the dark brown occur under 1 year of life. The majority of these perinatal or neonatal events. And then you have congenital anomalies or genetic, and then you have sudden unexpected infant death. So you can see the variation in the age group. So you have under 1 year, and then you have 1 to 9 years, and you have 10 to 17 years. You can see the variation of the causes and in different age groups. Malignancy often a big in the sort of the 1 to 9 year olds, also in the teenage. And then you have trauma, chronic medical conditions, infection, suicide or deliberate harm. So this is just to give you an idea of sort of, and this is obviously UK data, worldwide data or data in Sudan would be completely different to this. Number of CDOPs where they reviewed modifiable causes or modifiable factors when they are following the CDOP or the panel review, they identified modifiable factors. So if you look from 2020 until 2024, the review is sort of rising very slightly in 2024, that there is that the modifiable factors are rising very slightly, if you can see. What do we mean by modifiable factors? So things like perinatal events, chromosome, these, if you look at the sort of the data, the statistics between in each cause and whether they identified modifiable factors or not. So it's sort of 50-50 in the perinatal events. It's less in the chromosomal and congenital anomalies. Obviously, malignancy is quite significantly less, but infection, if you look at infection, it's quite high. Trauma and external factors and deliberate injury due to neglect or abuse is very high, that there was modifiable factors. When we say modifiable factors, these are modifiable factors in a child under 1 year. So things like smoking in parents, increased maternal BMI, smoking in pregnancy, unsafe sleeping arrangement or co-sleeping, issues with treatment, including delays, guidelines, policies not followed, parent substance abuse, poor communication, information sharing within agencies, and issues in diagnosis. So issues in diagnosis is less. As you can see, cigarette smoking in general is massive. And then co-sleeping, and this is all for children under 1 year of age. That the factors completely change if you look at the older kids from 1 to 17. The top one on top is poor communication, information sharing between agencies, which is quite striking. It's a massive number. Lack of appropriate supervision, issues in diagnosis, acute and sudden onset of illness, lack of recognition of deteriorating symptoms and clinical signs, which is quite significant if you look at the data. And then this is the proportion of children who are known to social services, who are known. This is a proportion of children who were known to social care or had previously been known to social care at the time of their death. So 15% by the end of March 2024 were known, and a further 14% were previously known, and the case was closed. So in 400, almost 500 reviews in that year, 46% identified modifiable factors out of those who were known to social services. So you can see again, that's steadily rising, those that they were known to social care, and that just reflects how social care is overwhelmed and the services are overwhelmed. So how we have to be, as clinicians, we have to be at high alert of all sort of social factors and take a holistic overview when we see patients, even if it's just a quick encounter in A&E. And this is sort of the number of deaths, 2024, 3,577 deaths, which is about 3 in 100,000. And the majority of those, if you can see in the line on the bottom, are in the, and the line on the top are the less than 1 year olds. And the majority of those numbers would come around perinatal and postnatal death, which is the majority would be related to prematurity. This is just by region. So if you can see the dotted line is sort of the national sort of average. You have sort of West Midlands and Northwest are sort of higher. And you have Southeast, Southwest and East of England are on the lower. And that obviously, again, reflects sort of socioeconomic health inequalities. So you can read a lot into this slide. And this is just a breakdown by sort of ethnicity within different groups. So the highest mortality is in Black or Black British ethnicity, followed by Asian or Asian British ethnicity. But within each group, you can see the numbers. So the lowest is in white. However, if you look at the group of white, you can see in the Irish traveller group, it's quite significantly high. So again, demographics, health inequalities, and health education, all that you can read into that on that slide. And then again, this is where death rates of infants who resident in the most deprived neighborhood in England were 5.5 per 1,000, compared to 2 per 1,000 in the more affluent or wealthy neighborhoods. So there's a very clear correlation here. Okay, so that's a bit about the statistics. I'll move on to the child death review process itself. So before I start, anyone in the chat can tell me just someone give me a quick understanding, or if you'd like to put your microphone on, what is your understanding of the child death review process? What happens? So a child dies in hospital, what happens then? I know I'm here to teach you that, but I just want to gain, does anyone know what happens afterwards? Anything in the chat? Yeah, I think someone's put their hand up. Ashwag?
Yes, maybe we have to communicate with the parents first.
Mm-hmm.
And also before that, we have to do a detailed examination.
Mm-hmm.
if it's possible, we can take history after when we feel that the parents are ready to talk.
Okay. So
But
that's sort of,
but before that's all, we have to be gentle, feeling compassion with the parents, because at the end they lost their child, regardless they were harming the child or not. We are not sure yet, but we have to be compassionate with the parents and help them and support them in improvement, of course.
absolutely. Absolutely. So these are, I'm going to talk a little bit before I talk about the process currently. Why was there a need for reform? So there was changes in 2018 made to the child death review process. So these changes came because there was wide variability in what each region did, or which each trust did, or each local authority. There was massive variability. So the aim in 2018 was to bring everything together as a sort of a unified, standardized review process across the UK or across England. And there was no sort of minimum review caseload requirement for each area. So you would get, it would be kind of haphazard of how many they would need to review within a given time. There was large variation between local government arrangements. There was lack of standardization in data collection. And there was limited collation and sharing of information between agencies, and even sharing the learning within the local authority. And the main focus was on the medical learning, not sort of now things focus on systems learning as part of the PSERF and how we can improve our protocols, our pathways, our service development, our service provision, and how we think about things like human factors. Before it was just very clinical, very medical. And then in the times now of digital transformation and data collection and the ability to see data from different areas, the collection of data all in one place is really, really helpful. So what were the changes in 2018? So they created something called Child Death Review Partners, which are consisting of the local authority and the integrated care body. So they would appoint the CDOT panel, who would be responsible for reviewing all the death in that given region. It became a statutory requirement, so the government produced a SOP, or operational guidance. It's available on, if you Google just Child Death Review Operational Guidance, you'll have, it was first issued in 2018, and the latest update was in 2024. It's a long read, but it's very, very informative if you're bored or you want to have a look through that. It's very informative. So now it's a statutory requirement that this child death review process is followed in all places across England. And then enhanced review processes like child death review meetings, child death, the CDOP or the child death overview panel, which previously weren't available. So it would be variable what would happen from one death to another, who would be leading on it, who would be investigating it. So now these are sort of standardized, and they have, each sort of CDOP has a caseload of about 60 per year. Then the ECDOT, where you can upload the forms and the death notification and all that, is all in one place now. And then you have to submit data to the National Child Mortality Database, where they produce these lovely graphs, well, not lovely, but informative graphs, where we get an understanding of the direction of sort of healthcare and where the learning comes from. And then there was some administrative changes. So previously we had Form A, B, and C. Now this has been replaced by Child Death Notification Form, A, and B by Child Death Reporting Form, and C, Death Analysis Form. Form A1, D, and E have been removed. And all these forms are on the government website, and they're very easy to access and self-explanatory. And then they identified new roles were identified, like a key worker, who was a person who's in direct contact with the with the family, is one point of contact with the bereaved family to give them that information. Before that wasn't there. So the family was sort of at a loss. They would be coming back to the department, they'd be coming back to A&E, they'd be trying to reach out to the pediatrician, to their GP. So having a single key person who would be a point of contact to the family, that really helped change in the bereavement process. So this is sort of a graph explaining when a child dies, what happens. So the child dies, then there's immediate decision-making and notifications. That is what you will need to do in the acute setting in A&E, or if you're the pediatric registrar or the peds A&E team, that would be your role. And then following that immediate investigation, you have that immediate notification and decision-making. Then you have investigation and information gathering. And following that, you'll have a child death review meeting, which will then lead on to sort of the CDOT meeting, and sort of learning will be shared nationally and locally. And on the other arm of that, we mustn't forget that the support for the family needs to be ongoing through this whole process, this is a long time. So the timeline of this is not, it's a long timeline. So we need to remember that the family need to be supported, and we need to focus on learning and national learning, and submit all the data to the National Child Mortality Database. Okay, so your role in the acute setting as the pediatric registrar or the pediatric consultant or the PZD registrar or the PZD consultant, what will be your role in the acute setting? Obviously, it's very distressing clinically, so we're not going to go into the clinical aspect. Once, obviously, the decision has been made that the child has passed away, or we're going to stop resuscitation, or the child has come in dead, or whatever the circumstance is, then you need to sort of activate the child death process. Every trust will have a sort of a death, most trusts will have a child death pact, so you can just print that out or put it up on the screen, and you need to follow it. Just a reminder for registrars, if you have a child that's come in cardiac arrest, your consultant needs to be called in. They need to come and attend. And usually we don't sort of declare the child dead until the consultant is on site, or if they give you clear guidance over the phone to stop CPR. I'm not going to go into sort of clinical because this is not, but just if you're in the middle of the night and this happens, it's always good to discuss it with your team. So your CPR is ongoing, your consultant is aware, your consultant is on the phone. If you're leading this cardiac arrest, does anyone else have anything we haven't thought about? So just make sure everyone is on the same page that this child is going to die, and everyone is aware, and there's no point of continuing resuscitation. Just you need to hear from everyone and make sure everybody's on the same page. Okay? So what's your role in the acute setting? So you need to notify the parents, as Ashwag said. Sometimes the parents will be in the room, and they will, but you need to, the first thing you do when the decision is made to stop CPR is you need to straight away notify the parents. So you need to, as we've learned in our communication scenarios, and we've been training for many years how to break bad news, but it's never easy. We train for it. It's never an easy thing to do. However, it has to be very clear, and you have to be very frank. No matter what you say after that, the first thing you say when you're breaking bad news is it has to be very clear. You can't say, oh, she's very sick, oh, we don't know. It has to, if you have called it, you have to say, I'm really sorry, but your child has passed away, or use the name of the child. Please try, and if I know it can be a busy situation, you might, but please try and use the name of the child, and it has to be very clear. If the parents are sitting down, you need to sit down at their level. You can't be standing up and like talking down to them. Sometimes I often sit on the floor in front of them. Sometimes it depends, your personal preferences. And then following that, there will be different response. Obviously, there's variation in how parents respond culturally, for religious reasons, for whatever reason, there will be different ways in how family will respond to grief and respond to hearing that news. It's never something easy for any family from all walks of life, no matter what. It will never be an easy moment. You need to be culturally sensitive to how parents react. And you need to give them that space to grieve and react. Okay? There are occasions where parents will become aggressive. They might start to try and like throw things about, or if I had people like pushing the crash trolley, there will be the sort of knee-jerk reflex will be they will come and want to lift the child up. That's okay. Let them support them, let them carry their child, let them hold their child. It's fine. If there's any concerns that the family will be obviously aggressive towards staff members, then you need to obviously call security in that, but do it in a sort of a gentle way. Be mindful of what they're going through. And then you need to identify available facts around the child death. So you need to so if the child is brought in by ambulance, you need to scrutinize the ambulance handover. You need to get what they saw at home, what were the settings, what resuscitation they delivered. Look at previous notes, GP visits, any facts around the circumstance of the death. You need to gather it as much as you can at that time. And then you need to determine whether the death meets the criteria for a JAR. So a joint agency response, as we defined earlier, is that we think this is an unexpected death. So a lot of child deaths are unexpected. So a lot of child deaths will have a JAR. And then determine whether you can issue the birth certificate or not, the death certificate or not. If it's going for a JAR, if it's unexpected, then you can't. You'll say it will need to go to the coroner. If it's a child that's palliative or known or has some respect document or a DNAR in place, then yes, you can. Any circumstances which are unexplained or need further investigation, you will not be able to issue a death certificate, and then you will just write that very clearly in the notes to the bereavement office that we can issue. And then decide whether a coroner referral is needed, and I would explain in the next slides when is a coroner referral needed. And then you need to determine if there was an issue relating to the service delivery. Obviously, any death will go to governance and will be looked at in detail in terms of processes, in terms of the service we delivered, and was there anything we could have done differently. And there's always learning from every situation. But if you're the registrar and you identify something immediate that is sort of a shortcoming from sort of from a medical perspective, then you need to alert. All death will be an incident report. And then you need to identify how best to support the family. And I'll come to supporting the family in the acute setting and following that a bit later. Fine. Then once that's happened, you need to submit a child death notification form, and that's done on the ECDOP. So that's a government website, a clear form online. You need to update the child health records. So all the child's health records needs to be updated that this child is deceased. You need to notify the GP. You don't want, say, the GP, they have an appointment, because if the child had booked an appointment with the GP a few days before, have the GP calling them up for their appointment the next day. You need to make sure that everybody that's going to contact that family and everybody who was involved with the child previously is aware. So any other professionals who have been involved with the child, if the child has this complex background, they would have had involvement from community nurses, they would have involvement from physiotherapy, from dietitians. All these need to be updated and made aware. And usually these children with complex background, they're professionals who are working with them would be very much involved with them and would know the family quite well. So they would really like to know on a personal level, not just on a professional level. And then we need to appoint a key worker for the bereaved family. And then in the acute setting, you need to carry out a hot debrief. Okay, I'll speak about the hot debrief a little bit later in the talk. So SUDIC or SUDI or SIDS, so SUDIC or sudden unexplained death in the child is a death of an infant or child whose death was not anticipated as a significant possibility within 24 hours before the death. Following investigations, then it will be further divided into those where there was a clear diagnosis or those where there was no diagnosis found. SIDS, or sudden infant death syndrome, is we describe it in children less than 12-month old. Older than 12 months, we say it's a SUDIC. So all SUDICs need a JAR and a referral to the coroner. All of them will need a body map. And the body map will be done by yourself as the most senior pediatrician. That would usually be the pediatric registrar or the pediatric consultant. It usually wouldn't be A&E like us. It would most probably be the inpatient pediatric team would carry out the body map along with the police, or the CAPE team, the child abuse team. And then there's lots of questions about investigations. So some hospitals in their sort of death pack would recommend that you do you get blood, especially if it's an unexpected death. You get bloods, you get a suprapubic urine, you do a lumbar puncture, you get swabs. It can be difficult sometimes to get these investigations. You can try a femoral stab, you can try an intracardiac stab, you can a suprapubic urine, a lumbar puncture. However, if the child is most likely going to the coroner, it's better probably not, because this is going to be carried out by the coroner anyway. Some hospitals, for their own sort of information and for their own records and own investigation, would require you to do these. Be mindful about moving lines and tubes before you have a discussion sort of with your senior person on the floor. If the patient was seen by advanced paramedics in the community and was intubated, or a patient with a complex background had an NG tube in place, or these need to be left in sight for the coroner investigation. By moving them and taking them out, you sort of may cause sort of discrepancies in the investigation. So try not to move anything unless you have a discussion with your senior. And then you need to consider the safety of other members in the household. So if there's other children at home and this is an unexplained or unexpected death, you need to think about, are they safe? Who's with them? Do they need to go into emergency foster care? Does the police? So the police, if there's an unexpected death, the police will go around straight away. And you may be asked to do a home visit, not as the A&E person, but possibly the pediatrician, as a home visit to with the police and social care. So these are sort of the immediate. So then a JAR. So when does a JAR happen, or the joint agency response meeting? It usually happens within 48 hours after the death, ideally, but usually takes longer. We do it if the case is sort of, we think it's an external cause of death, no immediate or apparent cause of death, or if the death occurred when the child was in custody or retained under the Mental Health Act, or we think the cause is not natural, or if it was a stillbirth which was not attended by a healthcare professional. So these all meet the criteria for a JAR. And then when do we refer to the coroner? So if the cause of death is unknown, the deceased is not being seen by a certifying doctor either after the death or 14 days before the death. If the death is violent or suspicious, if it's an unnatural death, death due to an accident, any accident will go to the coroner, any trauma, death due to self-neglect or neglect by others, death related to industrial disease or in your employment or work environment, death is violent or suspicious. I think I repeated that one. Death due to an abortion, death during an operation or following a general anesthetic, suicide in custody or detained under the Mental Health Act, or deprivation of liberties. So these all meet the criteria for a coroner referral. Then just thinking in the acute settings about, so what I discussed is all about a child that comes in cardiac arrest, a child that's previously well, or even if not previously well, but it's an unexpected death. But just thinking a little bit about palliative patients, obviously the same process doesn't apply. The same process applies in terms of the child death review meeting. The same process applies in terms of the CDOP. However, they will not qualify for a JAR. Or a coroner referral, obviously, and you will be able to issue the death certificate. Usually it would be issued by their primary team, so if it was an oncology child, or they would usually support in issuing it. So when a palliative child comes in reaching end of life, you need to clarify the DNAR status, read the respect document very well to understand the wishes, what has been agreed, and is this document valid? Please look at the dates to make sure the document is valid. Respect the wishes of the parents on this document. Think about the environment. A&E is not the best environment for end of life. So if you feel that that you have time to get the child to a better environment, like at a side room on the ward, where there's more support. If these children are palliative or complex, they would be very well known to the ward. The nurses would know the family well. The different sort of multidisciplinary team would know the family well. So it's better they be placed with. A&E is an environment where you have a quick overturn. We rarely get to know families. So it's better at this time that parents be aware with people they have met before, they're known to them, they feel comfortable with. A&E is a busy, crazy environment. It's not the best. So think about that. Think about getting the child, if you have the time, to a better environment. Think about who's best to support the family. People they know. You often people with children with complex backgrounds. I remember I had a child who came in cardiac arrest. They had a significant background. The first thing mom did when she found the child was unresponsive was call her community nurse. She didn't call LAS, the ambulance. She called the community nurse. That's the level of bond and relationship that these professionals have because they work with the family for a long time. So think about who's the best people to be around this family at this time. And then always honor the family's wishes and child's wishes in terms of, and be respectful to their cultural wishes and religious wishes at that time. So this is slightly different, but just if you are the reg at night and they bring in a palliative patient who's reaching end of life, please be mindful of these things to really clarify the respect document, to read it and to read the dates on it, to clarify what's on it with the family, and think about the environment. Think A&E, as I said, is not great for these kind of things. Okay, and then if we go back to this slide, the flow chart. So we've established the child is dead, then we go to immediate decision-making notifications. So as I said, notify the family, do the death notification, determine whether the child needs a jar, determine whether the child needs referral to a coroner, body maps, blood tests, samples and whatever. And then obviously supporting the team and the debrief, which I'll come to later. That's the role in the acute setting. Then the next step is there'll be an ongoing investigation and information gathering. And this is the jar and all that is part of the acute. So the ongoing investigation will be the team assigned to this will be usually the bereavement team, senior nurses, senior clinicians who have been involved and trained in bereavement for a long time. So they will be collating information from all agencies involved in the care of the child and complete the child death form, which is the next form, which replaces Form B. And then some hospitals will hold a post-mortem, even if the death was sort of didn't meet the criteria for a coroner. Some families will request it, some families will refuse it. So in this case, if the death doesn't meet the criteria for referral to a coroner, then the family have a right to decide on whether the child goes for post-mortem or not. However, if the death reaches the criteria for the coroner, then essentially the deceased is the responsibility of the coroner. So the parents sadly have no authority over the child while the deceased is in the care of the coroner. So the family cannot refuse postmortem, they can't refuse investigations by law. So, but however, if it doesn't meet the criteria of a coroner and you're doing a local hospital postmortem, then the parents they have the right to ask for it or refuse it. But the coroner, by law, they have no right to intervene. I don't know what my organizational skills you can see. And then then the local governance processes have to happen following that. So all deaths, as I said, will be measured as an incident report. All will be presented and discussed at local governance in the trust, sort of the trust governance, and then we'll follow sort of the PSERF, whether the death meets the criteria for an AAR, or whether it meets for a PSII, depending, but all deaths will be discussed at local and trust governance meetings. Okay, the child death review meeting then should be held within gathering all that data and collating that information and filling the second form. Then the child death review meeting should be held within 3 months. And then to complete the child death analysis form. Then within 12 months, see, lots of meetings. This is why it's confusing. This is why people, and I'll share these slides so you can get the process in your mind. To know it for yourself, if you're involved as a consultant pediatrician, you'll need to know it. And for your START assessment also, you need to know it. Okay, so the CDOC meeting will be held within 12 months, and then the learning should be shared from that, and then annual reports will be collated and distributed. And then supporting the bereaved family. So that's the next sort of step. Special circumstances, if a child died out of area, it's the responsibility of the local CDOC to review that death. Even say if a child went on holiday from Manchester to London, it will be the responsibility of the London CDOC to review the death. However, it can be at the discretion that maybe if that child was really well known, that child was complex, it may be transferred back to the local region. If a child death happened overseas, if a child death happened in custody, so there are certain circumstances where it would be the local CDOC rather than where the child is living. And then supporting the bereaved family. So what's a key person? A key person is a person who acts as a single point of contact to the bereaved family, who the family can turn to for updates, and they will be given updates about the child death review process. They can signpost the family to bereavement support in their local area. And just explain everything really, really well. And it's often a senior nurse, sort of designated nurse for child death within the trust, usually people with extensive safeguarding background and children's nurses most likely. They should be reliable and readily accessible to the family. They should coordinate meetings between the family and other professionals. They should offer bereavement support. And also they represent the voice of the parent in meetings. So often parents are grieving, so it might be difficult for them to attend these meetings, or even if they come, they don't feel they're able to speak. So the key worker would have had discussions outside those meetings and would represent the voice of the family. Supporting the family in the acute setting, so use very clear language, avoid jargon in your medical terms. As I said, when you're talking to the family, sit down, take the family to a family room, a nice quiet environment in A&E. If there's no family room in A&E, use a cubicle which is quiet, put a screen up, make everyone in the department aware that there's a bereaved family in there, so people are not coming in and out and, oh, where's the otoscope? Oh, where's the... So make it very clear, put a screen up, and sit with the family, give them time, assign somebody to the family during the acute setting. You won't be free to sit all the time with the family. Yes, as a senior person, you have to notify them, you have to talk to them, but there needs to be somebody with them all the time. And please assign somebody that's senior enough to be able to explain what's going on and explain, and has had that experience. So a senior nurse, a children's psych practitioner, somebody that's senior. Don't put like the medical student in there or the nursing student. Somebody that's senior enough even for the student themselves. It's overwhelming to put them in that situation. Oh, you go talk to the parents. So it needs to be somebody senior enough who's able to support the family. Some departments, they have a psychologist, which are really, really helpful. And then think about advocacy services, chaplaincy. So there's a chaplaincy service on site. You need to ask the family their wishes. Would they like somebody from chaplaincy to come down? Even if the family are not particularly religious, the chaplaincy they have dealt with this all the time. So they're very, very good at talking to the family, explaining the process. So if in hours, bring them down. Also out of hours, there are chaplaincy available. So call them, they're on call. And then think about language. So it's very important to speak to the family in their own language. So try and, if possible, to find somebody who can speak in their same language. There are options of language line and that, but it's not, I personally think it's not a situation for language line, and you need a person, but not always you can find that. Be honest and explain the next steps. Give a realistic time frame. So don't say because different cultures, different religions, for various reasons, people always want things to happen quickly. In many cultures, whether that be burial for religious reasons, whether people want to travel to be with family abroad. So you have to give them a realistic time frame of how these things are going to happen. Ask the parents their name and address them in their name. Don't say mom, dad, and refer to the child by their name. Don't say the deceased or your baby or your child. Use the name of the child. Offer the parents to come in if they can and participate in caring for the child, washing, whatever is the sort of last offices. And let the parents spend time with the child before the child goes to the mortuary. They need to have that time with their child. They need to hold their child. And then all trusts, we do what's called a memory box, is where they do photo footprints, and just a few things for the parents. And again, ask if they want a religious representative from the community who can come and help them. And at that time, we need to allocate a key worker. And very importantly, once the child is gone to the mortuary, ask how the parents are getting home, who's with them, where are they going, can we help getting them home? Think about little things, but think about them. And then ongoing support, the key worker to contact with the family. The key worker will also organize visits to the mortuary. Will be able to support the family booking those visits while the process is ongoing. And they'll explain the requirements and processes. And then you can offer, as a pediatrician, the senior pediatrician, you can offer a meeting in 6 weeks. This would be the general pediatrics, not us, but offer a meeting within 6 weeks or follow up in writing to the family. And some you can meet them a few times. It's not just once. This is a memory box, example of a memory box with things inside. They will be available in most trusts, and this will be given to the parents. And then supporting your team and looking after your team. So a hot debrief needs to happen straight after, usually once the child has been taken to the mortuary. So yes, we were trained to deal with death. We're trained to manage these kind of stressful situations, but no matter how much training you have for these things, in the end, you're human. In the end, you will be standing there. You will be relating this to your own life, most likely. You'll be thinking about your own children or your siblings or your cousins, or everyone will relate this somehow to their own life. And I know we say, okay, the child has gone to the mortuary and let's carry on and let's look at the board and send this one to CDU. But we have to have that 5 minutes just to process what's going on. The hot debrief usually be led by the most senior person in the room, or sometimes the resource team. The resource officers are very good at doing that. So in hours, they would be happy to support with that. And it just allows people time to process and talk through the event and what happened. It's not sort of like sort of scrutinizing what happened and what we could have done better. It's just letting people talk. So most likely somebody would go through the timeline of the events and what happened, and then people would open up gradually and talk about how they feel. Sometimes you might need people to step away. Some people get too overwhelmed. They might need a break. They might need to step off the floor for a bit. So you need to be mindful of that as a senior person on the floor. Then a cold debrief will be organized a few weeks later, and that is more thinking about what we will do differently, or what could have we done, reflecting on things we could have done differently, or lessons learned, or things that actually went very well. So it's more of a learning, the cold debrief. The hot debrief is a sort of a well-being check. If it's sort of you're the registrar or the consultant and you have an SHO or an F2 this is the very first time they've witnessed a child, they think about letting their educational supervisor know so they can support them. Think about psychologists in the department. For those of you who are in training, I'd recommend you to do the Bereavement UK courses. And there's a very good website called SANS, which have lots of courses and training for breaking bad news and sort of supporting families and parents. Oh, I wish any questions?
Thank you very much, Dr. Baasher. That was a very thoughtful session. There are a couple of questions. Someone asked, what happens if parents refuse investigations?
Depending on the situation. So if it's an unexplained death, then it's definitely going to go to the coroner. Essentially, they can't. By law, they can't. If it's a palliative, or well, if it's a palliative child, we wouldn't be investigating anyway. But if we don't feel it reaches the criteria for coroner referral, then parents can refuse a post-mortem. But most likely, a lot of child death cases will go to the coroner. So they by law, they can't. And you have to make this very, very clear to them.
Okay, someone else asked, so assuming there's an endotracheal tube in situ, can it be removed if placement is confirmed by another senior member from anesthesia, or should it be left in situ until post-mortem?
It should be left in situ. If this case is going to the coroner and this child was tubed in the community, for example, it should be left in situ. It should be removed by the coroner.
All right. Do we have any more questions, guys? You can pop them in the chats. We have just a few more minutes.
I think we have one question. Can we take intracardiac bloods if this is the only way and all other routes, or we're unsuccessful?
You can.
Yeah. Someone was also asking about the death qualifying referral for coroner. If that, I think you've been through this, but if you can.
Yeah, I can go back over it. So basically, any death where there's a suspicion that it's not straightforward. Basically, let me get this. So yeah, so the cause of death is unknown. If the deceased has not been seen by a certifying doctor after the death or 14 days before the death, so if they find somebody dead, then that needs to go to the coroner. Like you find the child dead, well, hopefully we don't find the child dead at home, but like if somebody is found dead, if there's violence or suspicious circumstances, the death is unnatural, death due to an accident, as I said, neglect, personal neglect or neglect by others, death related to industry, violence and suspicion, abortion, surgery or following operations or general anesthetic, in custody or detained under Mental Health Act, or those who have had dulls or deprivation of liberty. So these are all, so anything that's just not straightforward basically will go to the coroner. And with children, there's a very low threshold for the coroner. It's mainly the palliative children, the children with a very clear diagnosis and reaching end of life will not go to the coroner, but the majority of child death will go to the coroner.
Someone asks, can you explain if the death happened in the theater, what needs to be done?
Happened where?
The theater, maybe having a surgical procedure.
Mm-hmm.
What needs to be done?
So we'll need to go to the coroner. Well, obviously the same process will apply in an acute setting. So you need to, obviously you wouldn't be involved, I hope. I hope there'd be surgeons and anesthetists, but the same applies as what would apply in the acute setting for us. It would apply to them. But this would definitely go to the coroner because it needs to be investigated.
There's one about if despite a DNR, parents still want to go to a coroner, do we have to do a coroner referral?
I'm not sure on that one. I'm sorry. And that's I wouldn't want to give you an incorrect answer, but I'm assuming the coroner, we make a referral. It's our decision to make the referral, not the parents. So the parents can request a post-mortem, a hospital post-mortem, but they can't request a coroner referral, from my understanding, because it's professionals who will make a coroner referral, not the parents. The parents can request a post-mortem, a hospital post-mortem.
Someone asked if ECG is mandatory to confirm the death.
Well, I'm assuming you'd have cardiac monitoring on when you're doing, you'd have the defib. So yes.
Regarding the tube, Nadia, you mentioned if the child was intubated in the community, we will leave this to the coroner. If we have intubated in A&E for resuscitation, do we also leave it? This is a number one question. Number two, does this also apply to other lines?
Yeah, it applies mainly to lines which were placed outside the hospital. Inside the hospital, have a discussion with your senior around it. It's sort of case dependent, but lines placed in the hospital can come out because you have placed them there and then. But lines which were there before or placed in the community need to stay there. But again, it's case dependent because you have the senior person has to assess the resuscitation and the sequence of resuscitation and what happened. So to make that decision. So don't remove anything unless you discuss with your most senior person, whether that be the PZD consultant or your pediatric consultant.
Sorry to interrupt, but in Leicester, an ET tube can only be removed if it's been seen to be in position by two physicians that are trained in placing tubes. So two anaesthetists or CICU consultant, ED consultant that are trained in positioning tubes. If you're unsure, it's best to leave it. Sorry to interrupt.
Yeah, I agree. Thank you.
We have more questions, but I think we can leave it until the end of Habab's section, guys.
Yeah, that's fine. We will record all questions for the end. Okay, so now we have 10 minutes break. So another drink, stretch your legs, and come back for the last session. Very, very important and interesting session. See you in 10 minutes.
So I think we're about to get started. I'm not sure what happened to my camera, to be honest. It's completely blurred. So I've got the honor and privilege of introducing our next speaker. So we've got Dr. Habab Makki, a highly respected consultant in pediatric emergency medicine here at Leicester Royal. She's a graduate from the University of Khartoum and has been working as a consultant for the past 7 years. In that time, she's undertaken several leadership roles, including serving as a safeguarding lead for the Pediatric Emergency Department. Dr. Makki is a dedicated educator and currently serves as an examiner for the Royal College of Paediatricians and Children's Health. In her professional interests extend beyond the hospital. With strong commitment to global and humanitarian health, she works actively volunteers with the UK Med, contributing her skills and health crisis around the world. We hope for a very exciting interactive session, so let's join Dr. Makki.
Thank you, Robin. Good afternoon, everyone. Assalamu alaikum. So thank you to the faculty and moderators for the excellent day so far. I think depending on where you work and the context where you're based at, the safeguarding cases can be a bit different. The ones today are from the ED, so there have been patients who've come to the emergency department, and we've seen them in ED and then taken it further from there. Some cases can be a bit triggering, a bit upsetting, so I think if you do find them triggering, I can't. Okay. If you find them triggering, can you please get some support or reach out to someone to discuss it further? So today we're going to hopefully generate some discussions and maybe use the knowledge we've gained so far today to try and go through the cases. I've got 6 cases. We'll try and make it interactive. If you can pop your answers on the chat on the Zoom, and I can take a few questions after each case if that's needed. So moving on to the first case. So you're working in ED, you get a phone call from the safeguarding team telling you they've had a referral about the patient who came in 3 days ago. She's 18 months, so the note said that she fell from a dining chair at home onto her right side. Since then, the right arm hasn't been moving, and it gives whenever she leans on it. Examine her, you find she's tender on her clavicle. An X-ray shows she's got a fractured clavicle. So you sort that out, you send her home with advice about analgesia and refer to fracture clinic. Are you concerned at this point at all? Would you say yes or no?
No.
So no concern so far, yeah. Okay. So no, because as you go through the history, it matches the injury. So she fell off her dining chair. It's appropriate for her development stage. There's no delay. There are no other injuries noted, and you find that the parent and child were interacting appropriately together. So you do a referral anyways because she has a fracture under 2 years old. So in ED, everyone with fracture or burn under 2 years old is referred for safeguarding, just for review. This is part of information sharing. So what the safeguarding team will do is take the information you've shared with them and see if they've had previous presentations, if they have any previous GP attendances which were concerning, or any other things that was history concerning. So you find that at 9 months, she came to ED with a history of slipping off a slide the day before. She maybe rolled her ankle and wasn't weight bearing. The X-ray shows clear fracture of tibia. So you have an above knee plaster cast, and then she goes home with her first fracture clinic. And then after 2 months of that, she came again to ED. Lower limb previous plaster removed recently. Today she was walking, then she bent over, maybe twisted her leg, and now she won't weight bear. And the X-ray shows she has a previous fracture of her tibia, and she goes home again with a plaster of Paris. And again, you get referred because she was sent home as a fracture under 2-year-old, and there was a form. So I've got 3 attendances in 10 months with fractures. So at this point, are you worried now or no?
I'm worried.
Yeah.
Yes, I think everyone in the chat is worried now.
And again, for this patient, so you go back to the history again, you find it's consistent. She hasn't really, it's consistent. She hasn't really, the history fits with each developmental milestone. So yes, she came 3 times, but I think in the 3 times that she came, all the history was matching. So you had referrals which are appropriate, but so she had no safeguarding concerns. I think going back to Dan's talk earlier, we have failed a few children because they haven't shared information. So Baby P or Victoria Klimbe, or recently Sarah Sharif, she came to see a few health professionals, and people haven't shared the information, or people just thought that they wouldn't share them. So we've missed a few cases where we could have saved these children. So if you try and take a guess and tell me how many children die each year from child abuse in the UK, I've got 4 options. So if you can put A, B, C, or D in the chat.
We have different answers between C, A, and some B's.
Some B's. Okay.
Some D's, yeah, but a lot of A's and C's.
Yeah.
C.
I think in Dan's talk earlier, he did say that about 1 child a week die from child abuse. So 52 child deaths per year in the UK in the last 5 years were due to assault or undetermined intent. So it's quite difficult if you think about it. A weaker child death can be prevented just by sharing information or maybe better social services interactions. And 15% of children who died were no social services at the time of their death. So that's quite significant, a number of patients who were known who could have been saved. So this case highlights the information gathering and sharing information with other agencies like the school, the GP, the health visitors, and the clinicians looking after the child as well. I think it's important that we all understand that if you see a case and are concerned about it, we let someone know, because that could be the only time to interact with the patient, but there could be other interactions that they see other health professionals for it. I'm going to move to the second case, but were there questions about the first case at all?
Habab, I think we have one question.
Yeah.
Is there any definition or any specific definition about delayed referral?
So it depends. So we get this lots on ED, and again, sometimes a bit of it is maybe cultural. So say you've got a child who comes with a burn, and the family have applied some maybe turmeric or toothpaste because that's what they would do normally, and they come the second or the third day after the burn looks a bit more inflamed. Would that be a safeguarding case? Would it be a safeguarding referral, do you say? So they were delayed, but is that safeguarding as such?
No, so people are saying no.
Yeah, because they've tried doing something. So delayed, but because they've tried. If they've come in after 2 days and they've just left the child in pain at home and done nothing at all, then that will be a safeguarding thing. But again, each case is, you have to take it by context. So if they've been in a few times and every time they've come delayed either with an injury or a burn, then you might think that they might need some support. So take each case by context when they attend to see you. Okay.
Yeah, perfect. Yeah.
So move to the second case.
Sorry, before you move to the second case, can I just add?
Yeah.
For instance, this case we just discussed, we didn't have any worries because the history was consistent with the injury. Still, I don't know what the reason was that we reported the case at all to safeguarding that made them review the past medical history.
So for us in ED, every child under 2 years of age who comes with a fracture or a burn gets safeguarding referral. That's part of it used to be 5 years, but now it's 2 years. So if you're 2 years and below with a fracture or a burn, no matter how small or tiny, you get referred for a safeguarding referral. Not for safeguarding medical, but for a referral. So we can review if the patient needs more support or the family have been a few times, so we can see if you have any safeguarding concerns to be raised. Because like I said, you can miss a fracture and then they can come a fracture the next day and you miss that. So it's best to share information. So it's more targeted information sharing.
Thank you.
Okay, so the second case, again, is based in ED. So you have an 8-year-old who was brought into the emergency department. Her mom is with her and social worker with her under Section 47. Section 47 is a section where social services can present a child to you if they're worried about their well-beings, and you have to investigate them and do safeguarding medical. So school has contacted social services and said she's coming with bruises, and they want her to be reviewed in A&E. So she's coming for a safeguarding medical assessment. So initial review, you find she has bruises on her right arm. On her wrist, there's some swelling, you note as well. You do a body map, there's a few bruises you've seen, but mom refuses for a safeguarding medical. However, she agrees to have an X-ray, and X-ray is normal. So on the body map, you find bruises on her right forearm, you find bruises on the left eye, you find bruises on marks on both thighs. And mother admits that her mother sometimes gets angry and hits both her and her sister, sometimes with sticks. So what would you do if parent refuses to consent to the safeguarding medical? If you can just write thoughts and ideas on the chat. So if mom says, no, I don't want her to have a medical, I just don't want her to safeguarding medical, what would you do?
Report to social services, escalate.
They're already there with her, so that she is with a social worker.
Involve the police. We have include your senior, involve your senior.
Yeah.
Yeah, I think police and senior are.
Yeah. So these are all good options. So would you know who can consent to a child protection and medical assessment besides the parents? Again, just type in the chat what you think.
I
Social
believe
worker.
we need to get like court order if we are concerned about child safety.
Yeah. Okay. Right. So the consent can be done by the child, young person, if they're deemed to have capacity. Any person with PR, if they have capacity. The local authority, but they have to be under a care order. You can apply to a ward, so the High Court can apply, and then you can go to Family Procedures Court, but that's part of the Emergency Protection Order or Interim Care Order. So these can take time to process. So you can't force the parents to have a medical or the child without the parents' consent. So they have to consent to it. So there's no way you can force the parents for the child to have a safeguarding medical. You can involve the police, but that's only if you think the child is at severe harm. So at this point, she had a few bruises. The X-ray was fine. There was no life-threatening injury. So what we did in this case is we tried to speak to the mom. So we tried to convince her about the safeguarding medical. She said she'll think about it. Social services were involved. They spoke to the seniors. We spoke to the safeguarding team. And the agreement was that the child was discharged to a place of safety, so not home with the mom. She was going to come back the day after for a full child protection medical. The medical went on. There were no fractures, but there were some bruises, and her sister was reviewed as well, and there were safeguarding concerns raised, and they were removed from the family at that point. So again, this case highlights consent and who can consent to protection medicals. I think Dan said in the beginning of his talk about consent, who can give consent, and what we expect if parents refuse to give consent. Say if this child came in with like a bleed or life-threatening condition, then what would you do? Would you call the police and because it's a life-threatening condition, so they have an intracranial bleed or some other life-threatening bleed, you would probably involve the police at that point. So this is the second case. Sam, are there any questions about this case at all?
Yeah, just one repeated one. Is it below 2 years or including 2 years? That's a very specific about this.
1 year and 364 days.
Yeah.
So ours is 2 days, but again, safeguarding is not just by age. So if you have a 4-year-old come with a fracture, which is concerning, then you let someone know as well. So it's not really about age, but for us, it used to be 5 years. It's going down to 2 years. But if at any age you see something that you think isn't right, you just speak to someone about it. Discuss with safeguarding team, your safeguarding lead, or you just any seniors who are present.
All right. One more question. And children with sexual abuse, does police need to be informed, and who should inform them?
Yes, they do. So it's a criminal offense, isn't it? Sexual abuse. So it depends on the age of the child. And again, Dan mentioned the SARC. So police will be involved. You have to inform the police. You have to refer them to SARC as well. So the assessment, the sexual assault assessment center, referral center. But police have to be involved in all cases of sexual assault. You were going to ask about information sharing of the 16, 17, because if they have capacity and they say, I don't want to be, I don't want to see anyone, that would make it a bit complicated because they've got capacity to say, we don't want to be referred. And they have a choice. If you need them to have capacity, they have a choice. But again, it's a criminal offense that's happened. So you will talk to them, you'll try and convince them. And mostly everybody will be convinced in the end to be seen by someone to go through things. So most patients will agree to be reviewed by the SARC, and it will be raised to the police. But your job is to try and speak to the family, speak to the patient, and speak to the staff involved to try and make sure everyone's safe.
Okay, one last question and then we can move. Who should call the police? Is it our responsibility to call the police or social services?
So your responsibility. So it's a joint responsibility, but you can't leave it to someone. So if you see the patient, you will discuss with social services and you speak to the police. So it's a joint responsibility. You can't assume someone's doing it and say it's their job. It's everyone's job. If you see something, you sort it out. So you can speak to the police, you can speak to the social services, and you can agree who's going to call them, or you can call them yourself. There's no right or wrong because the police have to be informed.
Yeah, thank you.
But just make sure it's done by someone. So you can't assume someone's doing it and it's not being done.
Perfect.
Okay. Right. So your third case, again, it's an emergency department. So it's 1 a.m. You got a 16-year-old male who was visiting friends in Leicester. He said he jumped over a fence spike and he fell over. He has a chest laceration about 3 centimeters, sharp, like a clear laceration. There is no significant past medical history. He is alert. He is observed fine. He looks well. He's speaking to you. So medically, you're going to do this is his wound. So that's the wound, the photo of the wound. So medically, you're going to do a CT because he's got a stab or he's got a wound. So there's no lung involvement. He has some cervical emphysema to clean the wound, suture it. And he goes home with community nurses follow-up for suture removal. What are your thoughts about this case? So he's come to you at 1 a.m. He's jumped over a fence. What are you thinking in your head?
So we have suspicious, NAI, if a story doesn't match, history doesn't relate. Yeah.
Okay.
Look for safeguarding alerts.
As in previous safeguarding alerts?
Yeah.
Okay. So this is where professional curiosity comes in. So you're thinking, so you see a case, I know it's busy sometimes at ED, but every patient you see, you try and think, is this proper history? I'm missing something? Does it make sense? So for this patient, you have some concerning features. Why was he climbing a fence? Do you refer to safeguarding? Do you refer to other services? Do you take the history at face value? So sometimes you get teenagers coming and saying, I fell over a piece of glass, or someone pushed me. So do you take the history at face value or do you dig more into it? So for this young man, he lives in London. So we called his mom to come pick him up, but she wasn't willing to come. And she said he always goes missing for a few days, and he always comes back home in the end. He was arrested by the police once before, and his attendance at school has been around 80%. So what do we think is happening to this child? Or what's the safeguarding concern?
We have neglect,
Yep.
substance abuse,
Mhm.
fight, stab, knife.
Yeah.
Yeah.
Yeah, so it was a stab by knife. And we're thinking about child criminal exploitation, which is in the UK, about 14,500 children are being identified as probably exploited. Again, that's an underestimate, so they're probably more than that. And children as young as 12 years have been exploited before as part of CCE. So the different types, there's county lines, the people carry weapons, there's begging, there's stealing, there's house invasion, so different types of CCE. The risk factors tend to be special education needs, school exclusions, problems at home, so neglected home, domestic abuse, substance abuse by the parents. They usually peers, existing gang territory. So if they live in these areas, they might be easily exploited, and mental problems. And most kids will tend to join because they get money. There's peer pressure to join these gangs. They feel protected and part of a community, especially if they have problems at home with neglect. And they want to feel powerful. They want to feel that they are important as well. So county lines is a specific form of CCE. It's where you have gangs who exploit children and adults to move drugs between different locations. You often find children who move, so they might come to Leicester and they live in, say, somewhere down south, or they come to London and they live in Birmingham. So they tend to send these children around, and it's called county lines because of the mobile phones they use. So they have certain mobile phones, which they use to do these deals, and they must send children around on trains. So you might find an abandoned child, usually either injured or had some maybe sexual abuse, and they will be somewhere where they're not normally living. And that's why I have to be careful when someone comes to ED. he always needs to ask where they live because they might be moving between counties and different locations. So any questions about county lines, CCE, or stab wounds?
If this child is 16 and asks not to involve parents, do we still just involve safeguarding team?
So it's difficult. So this is a criminal offense. So if he's county lines, that's a criminal offense. So he is doing something which is illegal. So the police will have to be informed about that, especially if he's been dealing drugs and things. So the parents will know in the end. So you're trying to, it depends. You're trying to protect the child, you're trying to protect the family. So you're trying to protect the child. The safest thing for the child is that to inform the police, because he might be exploited. So they get abused, these children. So if you part of a gang, you are at a risk of harm. So you can be either stabbed, you can be sexually abused, you can be financially abused. So they're technically being exploited. And again, that might be the only time that you see a child, because they don't tend to come to seek medical health, so medical advice. So that might be the only time where you get to see them. And there's often lots of organizations. So in Leicester, we have a VIP, or Violence Intervention Program. So they are a group who are set in ED, and they will come and see these teenagers. So if you suspect someone's been stabbed, or they're being part of a gang, or you think that they are at risk of that, you can speak to this VIP team, and they'll come and speak to them in the department, and they will try and see if they can how they can support them. Because most of these kids usually have a bad home environment. They don't go to school. They haven't got much support around. So sometimes having a team like a VIP team, or someone where they can go and have some support, might be the only way that they are removed from these gangs and things. But being 16, it's difficult because they have capacity, but again, you're trying to ensure the safety of the child, and being a part of a gang is a criminal offense, so they have to be referred to the police. They have to be informed.
Yeah, that's fine.
Any more questions, Sama?
No, so far we're fine. We can have some questions at the end, though.
Yeah, definitely. Yeah. Right. So the fourth case. So this is a 15-year-old female who came to the ED with lower abdominal pain. She has some bleeding, but she said the pain is worse than the period pain, and her last period was 2 months ago. She suspects she might be pregnant, but she hasn't done a test. She came with a 31-year-old man who she says is her boyfriend. She speaks Bulgarian, so she needs a translator at this point. So this is what she tells you. So she tells you she lives with a cousin. She came 3 weeks ago to the UK with her boyfriend. She's staying in her parents' home. The parents have gone to Bulgaria. They don't know why. She thinks she might be 10 weeks pregnant. She's planning on staying in the UK for a long time. But you find that the boyfriend is doing, or the male is doing most of the talking and translating for her. So what are your concerns with this case?
We have trafficking, sexual abuse, exploitation.
Yeah.
Yeah.
Yeah. Yeah, so it's true. So trafficking, sexual exploitation, and she has no support in the UK, so she is dependent on someone to support her in the UK, so which would make her more vulnerable to trafficking and CSE. So what would you do with this case then? How would you approach this case?
Again, we have police safeguarding, sexual abuse team, SART.
Yeah. So the first thing I would do is get a translator, because you see that the male speaking for her, and she doesn't speak much English. So we'd want to get a translator to come and like try and take a history from her, because it's important to hear the voice of a child. you want to know what she's thinking, because it might be a different history to what you're studying. He might be saying something and she might say something else. You don't know what they're saying to each other. So translators and language barriers in ED can be quite difficult sometimes, especially any case, medical case, safeguarding case. If the patient doesn't speak the language, don't assume that the person with them is telling you the truth. Always get a professional translator to speak for them. So she had a strategy meeting. So the boyfriend changed his story and said he wasn't a boyfriend. He's a second cousin, and the parents are in Bulgaria in a funeral. When he found she was pregnant, he left. She was left in his care, but he brought her in because she was bleeding and in pain. So he is married with children in Bulgaria with the grandparents, and the police child abuse investigation unit say that she's not on the register. So they're happy that it wasn't child abuse case. She was on social services. She confessed she has a boyfriend back in Bulgaria. So she's been in the UK for 3 weeks. So she's pregnant before she came to the UK. So she got scared and said this was her boyfriend. Again, the police did a visit at home, and with social services, they're happy for her to go to her cousin's house. And she was referred to the teenage pregnancy midwives as threatened miscarriage. So again, this case highlights the importance of the voice of the child, listen to what the child says, and again, giving them space and making them feel safe to express their fears, because she was scared. She was her cousin. So if you had someone who sat down with her at the beginning and explained to her that she wasn't in trouble or that it was safe to speak about things, that would make it easier for you to get history. So she got discharged to the cousin's house, and I think she lost her baby because of threatened miscarriage. So she lost the baby after, at least the week after. I think in the UK, the under 18s conception rate has dropped down by more than half. I think it's down by 68% over the last few years. So it has dropped down, but there's lots of patients we see in ED now who are 15, 16 who are pregnant. We had a case where we had a 13-year-old who's pregnant as well. That is statutory rape, so you shouldn't be having sexual relationship after under 13 years. So I think that's different. So if 13 and 17 and 16 is different by age. So again, each case will be taken based on the presentation. So if this was a 13-year-old would come with this history, it would be different to a 15, 16-year-old. And again, this one said her boyfriend was 31. So again, that will raise concerns about, is she being exploited? And you'll find that child trafficking is it's very common in the UK. We don't tend to see much of it, but it is very common in the UK. So you will find that if you take a guess how many are trafficked in the UK each year, can you just give me a rough estimate of how many children are trafficked in the UK?
So we have 200, 5,500,
Yeah.
100, 15,000. We have many numbers.
Many numbers, okay.
Yes.
So 7,000, about 7,500 children are trafficked, identified as potential victims of trafficking. So that's quite a significant number. And of these, 78% are British nationals, followed by Albania, Sudan, Eritrea. So traffic isn't just for, because people seem to think it's Eastern Europe and Asia and African countries, but most of them are British nationals, if you think about it. So you have to think about, well, if you see a child, even a male or a female who come to ED with suspicions of being trafficked, you just need to raise these concerns again, because it could happen to anyone. Okay, so, and then before I move on to this case, any questions about this case at all? Can you hear me?
Yes, they can hear you.
Okay.
Someone has asked, was the police informed in this case?
Yes, they were, yeah. So they were. So there was a strategy meeting that involved social services, ED, and the police are informed as well, because there's a child abuse investigation unit, and they get informed about these cases where we're suspecting trafficking or exploitation, and they're involved in the meetings. So yes, they were informed, yeah. Especially she said he was 31, she was 15. So there was, if she was 31, then that's statutory rape as well, if she's 15.
Do we refer to SARC for forensic exam?
So she wasn't sexually, she wasn't raped, she was assaulted. So she was, if it's consensual, it wasn't abuse. But again, if you were thinking that she might have had, sometimes you might get tears who come to you and say they were in a party and they were sexually assaulted by a few people, or they were intoxicated, then you might want to refer them to SARC, yeah. Because that's sexual abuse.
Yeah, at the minute, I think that's all we have.
Yeah. Okay, so I'll move on to the next case then. So you are again in Annie. You're 15 years old female who has a background of ADHD autism. She lives in a care home on a 2-to-1 care plan. Over the last few days, her behavior has become more challenging, escalated. She started headbanging, started abusing the staff, attacking members of staff, pulling the hair. And the care staff brought her to Annie because they're not able to cope with her at home. And they said they can't take her back home. In ED, she continues to have dysregulated behavior. She is banging on the walls. She's picking things off the walls. She is throwing things at the staff. So the care home served notice and says that they're moving all the carers within 48 hours. So she remains in ED. She's seen by the CAMS team, who decide that it's not mental health issues, it's behavioral issue. I think over the last couple of years, we've had more of these patients coming into ED with dysregulated behavior from care homes who feel that they can't support them, they can't offer them much, so they will turn to ED as a place of safety. And we're getting more of these patients. Probably we get, I don't know, maybe 2 a month at this rate. And the department is busy and she escalates her behavior. What would you do? So you're busy, it's the middle of the night, she starts banging on the wall, she starts screaming. What would you do at this point?
Call security, contact crisis team, rapid tranquilization. I would talk to her.
Yeah.
Try to de-escalate verbally first. Yeah, that's talking.
Lorazepam as well, mentioned.
Yeah.
Chloral.
Yeah, most people said they would talk to her.
That's really good, actually.
Involve my senior and charge nurse.
Yeah.
Put in a safe room. Call family.
Yeah. These are excellent answers. So in our department, we have like a safe room 16, which has there's nothing there. It's just a room. It's got walls, but no furniture. We can move the furniture. There's nothing in there. So we tend to put these patients in room 16. We will call security. Sometimes security, when they come, the behavior escalates a bit. So you have to be careful where you place security. Sometimes some children, if they see them, they get a bit more dysregulated. So just make sure that they're a distance where they can see the child. And if they're upset the child, they can move back a bit and give them space. The question of tranquilization is a debate, which we often have in ED. I think adults are more quick to tranquilize their children, the adult patients in ED. In children, we're a bit more hesitant to do it. I think if you don't need to do it, why are you doing it? You're doing it for the safety of the department, doing it for the patient, you're doing it because they're making too much noise. Because sometimes you might say she's making too much noise, just give her something to calm her down. But again, in some context, that's a bit of abuse because you're treating someone with something that you shouldn't be treating them with. So they can sue you later on because that's abuse. So you shouldn't really be tranquilizing people if you don't tranquilize them. So if she's not harming the department, harming herself, harming the staff, you can de-escalate by just talking to her. And most kids will tend to calm down if you just go in and have a chat with them and try and de-escalate. Sometimes they trust a certain person, certain nurse, certain doctor, and you can ask that person to go and speak to them because they trust them. Sometimes the carers, they might trust some carers, and you might let the care home and let them know that this patient is escalating, so they can send someone who can talk to them. Sometimes social services, they have a social worker who the patient built a bond with, so you need to see what makes the patient calm down. It's a good idea always to have a patient. We have a patient passport, so it's a passport tells you what the patient likes, what the patient doesn't like. So that if you know what they like, what they don't like, you can always work with that. So you can de-escalate them. You can sometimes it's quite difficult because they've been ED stuck in this room for 2 days, like it's like a prison. So they are going to escalate. So if you can have the potential to take them for a walk or maybe go to the canteen, depends on the patient themselves. So try and de-escalate by talking or doing other things, and leave the medication or diazepam or chloro, whatever you give in your department for more severe cases where they're actually at risk of hurting themselves or they hurting the other staff members in the department. So does the trust have a policy for abandoned children? I mean, abandoned children is a term we don't like to use, but because they're not really abandoned, they're just left in the department. So some trusts will have a policy that they follow. So who to contact? So social services, you contact social services, you can go up to the chief executive. So there's a policy for what to do if you have abandoned children. So do you trust have these policies? Do you know where they're kept at all?
On internet?
Yeah. I think a bigger idea if you trust doesn't have policy, it'd be a good idea to try and work with the safeguarding team in your trust to see if you can develop a policy for these children, because ideally you should, so if someone presents to your department and they are left there, you should know what to do with them. And every trust will have a certain threshold for when they contact. So for ours, it's more than 24 hours, which we go down the policy of the abandoned children. So every trust have their own threshold. But it's good to have a policy where you can go to. So if someone comes to the department, you know what to how to correct them further. And again, if you think about it, the child's been left in ED. Do you know what needs we have to meet for this patient? So she's not a medical patient, but she is in the department. And we sometimes forget that these patients are in ED for days. We've had one once for about a week. So they are stuck somewhere. So what needs do you think we need to ensure met for this patient?
Mental, physical, educational, nutritional, psychological, food, hygiene.
Yeah, so for sometimes I think the hygiene thing for you have to offer them shower space, you have to offer them like sometimes they come with nothing. So if you can offer them a clean change of clothes, you need to make sure that they're eating a nutritious meal, so hot meal once a day. School, if they go to school, you need to make sure that the hospital school know about they're there. Again, it's difficult with the mental thing. So if you speak to CAMS, they come and say they assess them as they have the mental health issues. People tend to say, okay, so it's not mental. Mental doesn't have to be any of these like depression or psychosis. So sometimes there could just be behavioral will just need a bit of what's the word for it, right word for it. So if this related behavior, just need a bit of talking. So you might get the crisis team to come and speak to them, even if there's no mental health thing. They might just need to come and speak to them to try and understand some behaviors. So even if the mental health team say there's no need for them to come, just try and ask them to come because the patient might need some support in that area as well. But you have to ensure that patient's been there in ED for 10 days or a week or so. They have needs that need to be met, even they're not medical. There are other needs to be met for the patient. And just talking to them, playing games with them, making some member of staff to go and like sitting with them for a few hours a day, or that they feel like they are looked after. I think on the other hand, you want to make sure that you find that sometimes these patients will get used to being in ED, and we've had patients who've been to ED for a couple of days, so they get discharged, and because they feel safe then to return again, so if they can overdose to come back to ED again, because they feel this is where the safe place is. But you have to draw a line where you say we're treating you as a patient, but this is not a safe place to come back to. So if they see a safe, they keep taking over doors to come back to ED again, then they get discharged and they come back again because they want to come back to ED. So it's a balance between making sure that they're looked after and the balance of making sure that they don't feel this is a safe place. So they've got a home to go to. ED is not their home. It's just making sure that that balance is met while they're patients with you. Were there any questions, Nkechi, about this talk, about this case?
Only one, if talking doesn't work and they remain belligerent or aggressive, shouldn't they be sectioned?
Shouldn't they be sectioned?
Yeah.
So sectioning because you're aggressive, is a reason to be sectioned if you're aggressive, do you think? Why do you section patients?
Yeah.
So sectioning is
I think it's just when you don't have options, like you've tried everything, but there are no options. I think that was meant by the question.
So sectioning is it's quite complex. You have to have psychiatrists who come into the department, 2 of them. They have to see the patient. Assess. I think in the patients we've seen, I think it's only one patient was sectioned because they were psychotic. But section is not a straightforward thing, and it's not something we always. I mean, people push for it because it means. But the thing is, sectioning is probably not appropriate for every patient because some patients will have ADHD, autism, and that's how they behave if they escalate. So you have to understand why they escalate and try and de-escalate them, because sectioning might make them because you're going to think about it, you're going to restrain them in the department, you're going to get security to restrain them. Is that legal? Is it legal to tranquilize them? So there's lots of legality around it. So lots of things to discuss around restraining someone physically or by medication, because it might be illegal in some contexts. And that's why you have to take the advice of your safeguarding team and the mental health team as well, because you don't want to cause harm when you think you're trying to do good for the patient. So that's how you need to do. So I wouldn't say sectioning is the first thing. For someone who's being aggressive, you might try to you wouldn't physically restrain them because that would be sometimes illegal. But you find most times if you give them space, if you give them time to talk, most of them will de-escalate. And then if you think that you're not managing, then it's time to speak to the mental health team and see if they can assess the patient again. Or if you speak to the safeguarding team, they might have more solutions for you. But most times children who haven't got any mental health issues will tend to de-escalate after some time. So take it from there and then take it patient by patient.
Are we allowed to give medications without input from psychologists? I think you've already covered this. That's a repeated question.
Yeah, so no, every trust has to have a policy for tranquilization. So what medication you would use, doses you would use, and when you would use them. So every trust should have a policy for tranquilizing the patients. So you can use them in the middle of the night without any psychiatric advice, but then you have to think about why you're using them.
Yeah, thank you. I think that's no more questions.
Okay, cool. And then we go into the last case. So the last case, so you are again in ED. So it's a busy week, busy winter shift. You've got high acuity patients, you've got 2 in HDU, you've got a 16-year-old who came to you at after 1 a.m. with her friend who's 17 years old. Said she was at the party, she was sexually assaulted, looked intoxicated. There's no space in the department, so you keep her in the waiting room. And 2 hours later, once she finished a recess call, she is called to be seen by a medical team, and there is no response. You asked the nurse at the front desk. She said she informed the nurse that she was leaving, and a nurse advised her to stay, but she's not sure when she left. She just walked out. You tried to contact her, but there's no response on the mobile phone she gave you. So what would you do?
Police, all responses.
Yeah. Yeah, so you definitely call the police. This is a case of sexual assault and a 16-year-old. She's intoxicated, she's at the party, so there's lots of things which are In this case, lots of things which are triggering. The problem is, sometimes you're busy, and some patients will leave the department without being seen. Does your trust have a policy for patients who leave without being seen? Do you have, like, what would you do with patients who left without being seen? Even if they came with fever, or if they came with diarrhea, vomiting, does your trust have a policy of patients who left without being seen?
We ring parents or patients themselves.
Yeah.
No, we don't have.
Yeah.
So yeah.
Yeah, so in a trust, so you bring the patient. So we have a policy in our department. So patients who leave without being seen, you will go through the notes and then say if it's concerning, like someone who's had a seizure or someone who's had an overdose, you try to contact them and get them back. And then if not, it depends. You can assess how you need to see them then. But if patients leave without being seen, we have a process in the department where the next day, all the notes get reviewed by the consultant of the week. And then we go through the notes, and then we try and assess if there were any safeguarding concerns. And if we do have concerns of any patient, we call up a safeguarding team. And we try and get the patient back to ED again or back to the GP, or raise concerns for services. So all the patients who leave without being seen in the emergency department get reviewed the next day by the consultant to see if anyone needs to be called back in again. But for this patient, she is at risk of exploitation and risk of abuse because she was at the part assaulted. So you need to call the police there and then to get her back to the department or to get her back to a place of safety. So yeah, you're worried about sexual assault, worried about exploitation or trafficking because she could be trafficked as well. And that could be the only chance again that you see this patient. She might never come back to a health provider again. So again, every chance to see with a child or with a parent or with a patient, try and use that chance to, because that might be the only chance you see these parents or this family or this child. So try and use these opportunities as much as you can to try and establish a rapport, establish if they have any other concerns. Like Dan said earlier, voice of the child. So try to speak to them on their own, trying to get understanding of how they're living. So yeah, we called the police and they found out her address and they took her to SARC and she had the assessment and she was just at the party, she was assaulted, but there was no risk of exploitation or any risk of any trafficking and things. So I think for me, with these cases, I would like you all to list at least one learning point from the day and from the cases, from these cases. Just list at least one learning point that you might use in your practice, so you might change how you do things when you go back to your workplaces.
Listen to the child.
Yeah.
Know the local policies.
Yep.
Be familiar with your local trust policies. Ensure early escalation as soon as you notice any red flag.
Yeah.
Consider each case separate. Explore if there's clues for any safeguarding concern. Teamwork, communication. Teamwork. Yes, very nice. Listen again. Listen is very repeating. Good. Child's voice. Very good.
Yeah. So I think also that there's support available. So if you have any cases that you think you're not sure about, contact safeguarding team, and they are really good at giving support. Service out of hours, they are really good as well at giving support. You've got lots of other services for children come to you. And every trust will have different services depending on the trust. Information sharing is important. You see something, you're worried about it, document it and share information because you don't want to miss that chance that the child's come to you. You don't want to miss a safeguarding case, don't want to miss a chance that you might have saved the child or you might have protected them from further harm. Using translators and ED, so language barriers. the UK has become very, I mean, Leicester especially, is you've got lots of people who speak different languages. We can't speak all the languages, so make sure you've got professional translators who can speak to the child, speak to the family. Don't use family members for translation. And again, professional curiosity. If you see something and you doesn't make sense, ask. Keep asking the parents, keep asking the child, keep asking yourself, do I believe this? Do I trust this? Do I want to change this? Does this make sense? So keep using that. And the voice of the child as well is quite important as well. So listen to the child on their own. I think someone asked about what age you can speak to the child on their own. And like Dan said, there's no age. So as long as a child can express themselves, 8, 7, 8, 9, you can ask them, you can speak to them, give them a chance to tell you, even if they come with abdominal pain, if they come with chest pain, if they come with headaches or vague symptoms, give them a chance to speak on their own, to tell you what is worrying them, because there might be things that they can't express in front of the parents. So always listen to the child. Always make sure you listen to what the child is saying. And I think that's it for me. Thank you very much. Were there any other questions, Osama, at all?
Thanks, Habab. Yeah, I think we have some questions for everyone.
Okay, I will share and then we can.
Yeah. And then everyone can engage, please. Dan, Nadia, Nadeem, and Habab, feel free to engage. So I have a couple of questions. A 20-week-old baby was brought by ambulance team offering CPR. The baby was declared not fit for resuscitation. Do we still need to go through all the process of CDOP?
Osama, just wait for a few minutes for Dan
Yeah, it's fine.
to join, because this is a separate session as well.
Yeah.
I'm currently on, but for some reason my video is not working. Can you hear me?
It is now. We can see you and hear you.
You can see me now. Okay.
Yeah. Thanks, Habab, first, before taking these questions. Thank you so much. Very interactive, informative, as usual. Thank you.
Good.
So what was the question again?
So that was a 20-week-old baby was brought in by ambulance offering CPR. The baby was declared not fit for resuscitation in the hospital. So do we still go through all the process of CDOP? It's SIDS, isn't it? Less than 1 year.
So it's an unexpected death, but at 20 weeks, it would potentially not be viable. But with regards to this, I must admit I'm not an expert on that area. 20 weeks, it will have to be escalated, but it would be classed as a potentially non-viable pregnancy.
So, Osama, is it 20 weeks old?
No, not gestation, not gestation. 20-week-old
20 weeks
baby.
old, then yes, it definitely has to go through any death that's happened at home. The question is why? Why is this 20-week-old died? If the child had a major congenital heart problem, then on speaking to the coroner may state that further investigations aren't necessary based on the background, but I would always escalate it. Sorry, I thought you meant a 20-week gestation.
It's all right. If it is 20-week gestation,
It
just
doesn't
that's a different
matter
thing.
with regards to the what the child's age is. Any death in the community or within the hospital has to go down the child death process.
Okay. Let me just copy this. All right. So, who can declare child death? Should it be the most senior person or a trained person, or there are specific criteria?
So anyone who's trained to, I would always get someone else to do it as well, but typically it would be someone of registrar level who's working within the ED when the child arrives, or a consultant.
It's usually the person who's running the arrest. So if someone is the team lead for the arrest, they will tend to be the ones who declare death. Usually it's a team decision as well anyway. So if you're trying to stop resuscitation, it's a team decision. So you will discuss with the team, you will discuss if it's futile or you want to carry on. And then as a team, you will come to an agreement to stop. And then you will declare that the child is dead at that point. So it's a team effort. But mostly the person who's leading the arrest is the person who will declare death.
Okay, thank you. There is another question, I think, driven by some anxiety or fear of most of us. In unsuccessful resuscitation, is it common that parents will take the medical team to court? Like, are you blamed?
So taking the team to court, if the child was severely unwell and needing resuscitation, then the question would be why. Obviously, if the child has deteriorated within the hospital and there's worries about malpractice, then they may take the team to court. But if a child has come in extremely unwell and needing resuscitation in ED, why they may potentially take the team to court, but where are they going to go with that? Because the child was essentially almost dead and needing resuscitation. So I wouldn't worry about, I would get stuck in, do the resuscitation, and then explain to the parents afterwards whether you found anything that could indicate why the child has unfortunately passed away.
Yeah, thank you so much. How long does it take in emergency department to get court order for child protection medical? I think that was during the case when there was parents refusing or something like this. Habab's case, I think.
Sorry, Saba, can you ask the question again?
How long does it take in emergency department to get court order for consent?
For consent for child protection medical?
Yes.
Well, it's done by social services, so normally they will contact the court. It's outside, depends on the it depends on the context as well. So Dan, correct me. So I think if someone comes with a say intracranial bleed or something life-threatening, you don't need to wait for court. So I think you can do it for the best interest. If they come with a bruise or they come with like a maybe a burn or something, so a small simple burn, you can speak to social services and they will raise the issue to court or the police and things. So it depends. It's the context. So there's no time frame. I think it's 48 hours or something.
Child protection medical you wouldn't be able to do without consent. You can treat a child in the child's best interests, which would be just taking a simple history and initiating treatment. But for a child protection medical, you do need consent. And if you're needing consent from the court, obviously that can sometimes take longer than 24 hours. And sometimes up to a couple of days, depending on how busy the courts are and what day of the week and what time of night it is. Luckily, most parents, once you've sat down, explain that this is something that you have to go through with all children that present with these injuries, that this is standard practice, that we're not pointing fingers at anyone. We need to investigate what's happened, find out if the child has any other injuries, and explain to parents that a skeletal survey, if a parents come in and they don't know how the child has fractured an arm, state that there are multiple other bones in the body. We don't know whether any of the other ones are fractured, and therefore by doing the skeletal survey, we'll be able to see whether the child has any other injuries that need to be addressed. And following explaining those sorts of things, most parents will allow a child protection medical to take place. If parents are flatly refusing, then you need to document exactly what the parents are saying, raise it to social care, and then it will go to the court, and a child protection medical will take place with the court's approval. Obviously, if the child needs urgent treatment, this isn't a child protection medical, this is treatment, and you act in the best interest. If a child, for example, comes through the door bleeding because they've got a big gash on their arm which has severed an artery, you're going to treat the child, and then the child protection medical can be done when the child's stable.
Thank you so much. I think Habab answered this question, but because it's repeated. So 16 years old and 17 years old overdose something and they refuse investigations or bloods. What can we do?
I think I have that question as well. I think it was like how to address the management in a situation where a 16-year-old who's taken some overdose and she has capacity to refuse bloods and treatment management.
Okay, perfect.
Is that the same question, different questions, or?
I think it's the same.
Same. So again, it's, so 17-year-old has capacity. I was just looking at the chat, someone said you can do without her consent, but she's got capacity to refuse. So if what does capacity mean? Capacity means you've told her what to expect, what's going to happen if she refuses to have it done. You can't hold her down to do her bloods or give her treatment. She's 17. So if you explain to her that she's taken overdose, that might harm her, they might kill her, her liver might get damaged, or and she understands the consequences, then you can't force her to have blood test or pin her down. We've had a few patients who've come with that. So so again, depends on how much they've taken, probability of them having a significant overdose or overdose that might not harm them. So you need to take it by how much you've taken. Do you believe how much you've taken? You need to speak to them again as well. And I think, like Dan said, most patients, if you speak to them about things, they will after some time agree. Sometimes that's the only way of having control, is refusing for treatment or for bloods to be taken. But most patients, once sit down, speak to them, give them time, they will agree to investigations and treatment. But at 17 and she's got capacity, you can't hold her down. That's assault. So you can't hold them down to give them a medication that they refuse to have, or blood test they refuse to have. But again, take it by each case.
Yes, I knew.
There is another part also related in a different question. If someone similar age, it's all about this age, came intoxicated from a party or something, parents want to do urine for toxicology, should we do without the child consent? I think it's the same concept, same idea.
Again, you can't, she's 17. She is the patient of the parents. So you think about treating the patients or the parents. So they want toxicology to prove that she's taking drugs, or to what do they want toxicology doing? So again, talking is a very powerful tool. Speak to the parents and see what they're worried about. And you can speak to the child, wait for them to wake up. If they're intoxicated, wait for them. So toxicology takes a few days to come back anyway, so there's no rush. So you can wait for the child to wake up from their intoxication, and then you can speak to them and tell them this is what we want to do if you need to do it. And then take it from there. But you can't do anything without the child's consent. She's 17. So again, you can't without their consent. Again, I think this age group, we struggle as well, because in ED we used to see up to 16. Now we see up to 18 years old. I think we struggle with the capacity and understanding where the law stops with, like getting consent from children and parents. But that's why every case is different, and we're lucky we have a really good safeguarding team and a good mental health team in ED in Leicester, and we can raise concerns with them. So if you're worried about something, you can just have a chat. Social services are there as well, so you can always find someone to talk to as well.
Dan,
Yeah.
sorry, Dan, there's one for you because you mentioned needing to confirm ET placement by 2 senior clinician experts with 2 placements for ET put in during resuscitation in LRI. So would this confirmation be via direct laryngoscopy, or if seen with video laryngoscopy at time of placement, or is confirmation with X-ray sufficient?
Not with X-ray. You typically have to have a look down and direct look. We don't typically use video in Leicester. I'd have to check whether, I presume that video, if 2 senior consultants have seen the tube clearly go into the airway, then on video, then that would probably be okay. But the question would arise, has it fallen out as a result of resuscitation? And therefore, I'd probably say you'd need to have another look at the end before you take it out, just in case it has dislodged.
Right, thank you.
And I would check your local policies. Only until a couple of years ago that we were leaving all lines in Leicester, and different areas may have different advice on that. So definitely check your local policies on that one.
I have a question from my personal experience, if that's okay. So I was covering one of my night shifts in the emergency department where I saw a child with 13-year-old. She came in with abdo pain and it was severe abdominal pain. So when I dig on the history, she initially denied any sexual intercourses or sexual activity. And then that's because she was in front of her dad. Then when I spoke to her privately and I told her that I need to do the pregnancy test, she then told me that she's sexually active and she has a partner she is 13-year-old and he was about 17-year-old. But when I told her that I will do the pregnancy test, she immediately said to me, "Oh, by law, you don't have the right to let my dad know. I'm guilt competent." It was so stressful for me to have that kind of conversation with her, because I felt from my examination, I'm dealing with miscarriage or I'm dealing with a ectopic pregnancy. But her response to my question make me hesitant of what the next step. She clearly guilt competent from the way she's talking to me, and she clearly very aware of the system and law. So in that case, what's the best step to do and how I approach?
What did you do, Tony?
Okay.
I spoke to the consultant because she was around, and she was also felt it's very uncomfortable situation. She said to me, "Oh, okay, let's do the test first." Unfortunately, the test came positive, and still she said to me that you have no choice you have no even chance to say anything to my dad. I lied. I didn't tell her that. When he asked me why you are doing all these investigations, I told him that she has a problem in her tummy, so I'm gonna do further investigation. I didn't feel very comfortable doing this, and I'm still trying to sort out what's the best thing to do in the future, how I approach these kind of kids.
So a 13-year-old with a 17-year-old rings alarm bells with me. Less than 13, it's classed as statutory rape. 13 to 17, if a 17-year-old is having sex with a 13-year-old, that rings alarm bells, and I would raise that as a child protection concern. Why is a 17-year-old sleeping with a child that young? That raises concerns. Does the child, although they say they're guilt competent, do they truly understand what they're doing and any potential risks they're taking? And in this case, I would raise it as a child protection concern to the child protection team. Over 13, if you've got two, for example, 15-year-olds who are experimenting, who are having sex, then providing they know what they're doing, they're both consenting, then I wouldn't be as concerned. But although he's not over 18, 17 and 13 is a significant age gap. And the fact that he himself is over 16, he should know that he shouldn't really be having sex with someone under the age of 16, and 13 is very young. That would be my opinion.
Thank you, Dan. I handed over her to the next shift. I don't know if they proceed with this.
And you've also got to think about doing things in the child's best interests. Obviously, a 13-year-old may not fully understand the ramifications of getting pregnant, getting a sexually transmitted disease, and you need to think about that side of things as well. But I'd speak to definitely refer that sort of patient to the safeguarding team.
Sorry, Dan, just to follow up on that, what about speaking to the parents? Because like we assumed like she's getting competence, but apparently she put herself in a lot of risk by doing this. So what about the parents?
So with that one, I would raise it with the safeguarding team. I'd request a strategy meeting with social care and look at the background. But if she is repeatedly going out and sleeping with 17-year-old blokes, that's a concern, and you may have to inform her parents of that. But that's a very touchy area, and you need to make sure that the child understands why you're doing it and what you're going to have to tell them. But yes, it's a contentious area, but certainly if this child was less than 13, it would be classed as statutory rape and the police would need to be informed immediately. In a strategy meeting, a 17-year-old sleeping with a 13-year-old, the police would probably raise concerns and want to see this 17-year-old's background.
Thank you.
And Gillick competent, is this child truly fully understanding what they're doing? At 13, it's debatable whether they understand the significant impact that pregnancy, sexually transmitted infection are going to have on the rest of their lives.
We have a question about alcohol and intoxication. When or what age do we need to escalate to social services?
So for alcohol intoxication, loads of children will drink from early teens onwards. The time you inform social care, a one-off, if the child hasn't got themselves into a big mess, hasn't obviously got themselves attacked or abused, then you don't necessarily have to inform social care. If this child is turning up every single Friday night, completely drunk out of their mind, then that would raise concerns, and I would raise it to social care to see if there's anything in the background that we're not aware of. One thing we do need to be aware of is often we don't see the whole picture. You're seeing the child with their medical problems for 15, 20 minutes, and only by speaking to social care do you get a much wider picture of the child's life. But alcohol intoxication, in the UK, I was drinking at the age of 16. It was normal at my school on a Friday night for us to have a bottle of beer, bottle of cider. So you've got to think about, one, is this child putting themselves at too much risk? And is this a recurring theme? And is there something we should be thinking about in the background? If this child is drinking repeatedly, why is that? Is there something happening to the child that we don't know about?
There's a follow-up question to that. So someone's asked if the patient is 16 years old and they've come in intoxicated at a friend's party, but if parents come in and ask for a urine toxicology test, can that be done even if the child is intoxicated at that point?
Not for intoxication. If the child is worried that they have been drugged, then you may do a toxicology test just to check. But on the demands of a parent, if the child is back to normal, they're no longer intoxicated, then the question would be, why are we doing it?
I think we have one more question for Nadeem. It's about if parents have complained about the doctors blaming them for abusing the child, how would we handle the situation?
Sorry, just say it again.
So it's if the parents are complaining about the doctors saying that they are like blaming the parents that they're abusing the child, they've put in a complaint, how should we handle the situation?
I think every hospital department have a system in place regarding complaints. So I will just follow the system in place. Obviously, if you are senior person and you for example a trainee and can speak to a senior member there and who can have a chat with the parents, but obviously just to explain what exactly happened, but obviously if they still want to go ahead with the complaints, then as I said, there is a system in place in each hospital, and just follow that, just follow that, the procedures.
And you may have to give a response to it, but parents have the right to complain, but your response will be that I am acting under, I'm having to do a child protection medical because this child presented with whatever they presented with. This was agreed with social care. That's why you get the backing of social care, and the parents don't really have a huge amount they'll be able to raise on top of that.
Yes, I think just remember that whenever you see and do any medical, you're doing for the best interest of the child. Don't think that what the parents will think. Like, if you're thinking like, I don't want the parents to become angry, then you might miss something there. So just go there to make sure that you're doing for the betterment of the child, irrespective of the parents thing, because that's what your duty is a doctor. So that's what you should be doing.
And certainly when I'm doing a child protection medical, if the parents start getting very, very annoyed or very, very angry, that raises concerns with me as to, is there something going on in the background here?
Someone has their hand up. Answered.
Yeah, thanks. It was a very informative session. The whole way I've been following. So, on continuing of the last statement, I faced a situation like this recently when I came for the night shift, and the child protection medical had been started for a child. Already, the child medical was done, but I think this was a infant, and I think the mom was having some postpartum issues or mental health issues, mild one. And then the dad was not there, and he came later on my shift. And he came and he started blaming and said, "You have broken my wife. She has been crying, and he straight to me and said, you are blaming that we have harmed our child." So I had to deal with a situation like Dan was explaining. I said that this is in the best interest of the child, and I had to de-escalate the situation. The more of the factors issues, I would like to highlight that when there is two teams involved, like we are handing over on a team, it would be always ideal for the previous team to have explained. I'm sure that everybody is doing. Sometimes parents later on come and say that nothing has been done. So he told me that I have not been informed about anything. My wife was not informed about anything. They said child protection. That's it. We don't know what's happening. And so then I had to give the leaflet. I had to explain the process, and all that had happened in my shift. And the other issue I would like to highlight is about if they have come with the primary problem. This child came with the primary problem of not tolerating feeds or vomiting. And the complaint from the parent was that has not been looked into at all. And with seeing a bruise, and we have started the cycle of the safeguarding process rather than addressing the issue what they came with. So then I had to mention what we are doing about the vomiting and those issues. So I think that sometimes already it's a specific situation for the family, and then if you think that we are on to the child protection and not taking care of the primary problem, it really works around. I just wanted to highlight that. Thank you.
Yes, I think, Anzad, you are very true. And that's what I mentioned as well, because first consultation is very, very important. And you have to be very, very clear, very, very honest, explain everything. Then, go through with the parents again if they have any other questions. And this is not very uncommon. You mentioned like, they came for something else and then you just start doing child protection and just forgot about this one. So make sure that you address all the concerns, document and give in full details what you're going to do once you have confirmed with social services, and get the consent as well, because sometimes if you have done everything, got the consent, then all the procedures and investigations can be done very quickly as well. Otherwise sometimes they have to wait for long as well. So just be clear, get a very good handover, and especially the safeguarding, whenever you're handing over to the next team, make sure that you're very, very precise and just tell what have you done and what is left. And just again, go back to the parents again and tell them like, just keep updating them.
And remember that they may have presented with something else, and do address that even if you do find bruising or something else of concern. And that's why it's often good to get written consent beforehand, because then if another partner does come along and say, my wife didn't say you could do this, you can show them, well, we discussed it with your wife and she gave written consent for us to undertake a child protection medical.
Thank you, Dan.
I think that's it. Thank you so much, everyone, for this great day. Thank you so much for our speakers and all the attendees. It was a very good and informative day for all of us. So yeah, thank you so much. Each one will get an email with the feedback link. So please fill the feedback link, and then you should be able to receive your certificate.
Sorry, just one, Francis here. Just thought on the age discrepancy, I'd put a comment there. There's some, I don't remember where I had it, but some kind of arbitrary guide of more than 2-year age gap between, say, like the 13 and 17-year-old would probably trigger a referral to social services to have a strategy meeting as a kind of an arbitrary guide. So if it's more than 2 years usually, then the power dynamics usually is kind of should be taken into consideration. I don't know if that's still an ongoing thing, or has that arbitrary line moved? That was one of the questions that I had for Dan. And the other one was just a comment about the 16-year-old or 15-year-old refusing to have bloods to treatment for, say, paracetamol overdose. My understanding is children basically under 18, if it's nothing to do with mental, it's treated as medical. And whereas they can accept bloods and treatment, in terms of refusing, if it's not in their best interest, it can be challenged. Now, of course, you try the usual soft approach of trying to convince them and get them on side. However, if that's not the case, you probably need to involve the risk team and probably escalate it to probably court to help with that, or mediation if that's helpful. Thank you.
Yeah, with regards to 2 years, anything above 2 years, I'm not aware of there being a set guidance of 2 years, but certainly if one of the, if the boy or girl is above 16, the other one is younger than 16, that is a dodgy area. And certainly if, as you've said, above 2 years, that again, like you've said, could ring alarm bells, but it's best to discuss them. 13 is very young for a 17-year-old, and the question would be, what's going on? Is this 17-year-old using and abusing this 13-year-old? Because yeah, it's not typical for a 17-year-old to be going out with a 13-year-old.
Thank you. Yeah.
Just wanted to add regarding bloods and investigation for 6 years old. I think from my experience, I haven't come across like you are unable to get a consent for bloods. You can just use a different approach. Sometimes what I've seen is like they will say, okay, certain person or certain doctor, a nurse, I am okay for them to do the blood. So just try different approach, and that should work. I mean, very rarely we have to do something else, and most of the time just good communication, good talking to them, and giving some other options will definitely help.
Yeah, definitely. And the biggest one, if you tell the child that we're going to have to do this in order for you to go home, and the longer you don't have these done, the longer you're going to be in hospital, often they will change their mind.
That's true.
If they were both 13 years old, what would the situation then be? Or
So
younger?
if they're both 13 years old, if they're younger, it's still classed as statutory rape, but it would be statutory rape for both of them. If they were both 13 years old, it's still pretty young for having sex, but providing they both know what they're doing, they're both not taking advantage of one another. The difficulty is working those out. Do these two 13-year-olds, you'll only have one of them there. Does the other 13-year-old know what they're doing and not being taken advantage of in any way? It can be very difficult, and it may be useful to speak to social care. But over 13, 14, 15, you will have children having sex at that age. They will experiment. Just because the government have stuck that you have to be 16 years and older in order to have sex isn't going to stop lots of children having sex if they get the opportunity.
I think even down with marriage, because marriage is illegal under 16, but it's legal in Scotland at 16. So we've had a patient who came in a few months ago who was 16 and she was married, but she got married in Scotland. But she came to the UK as a married 16-year-old. So technically it's illegal to be married in the UK, in England, 16-year-old. So I think different context. So again, you have to understand we are here for the child, we advocate for the child. So you have to see what's best interest. So you just have to work with the child and the family. With consent, with anything, with overdose, or anything, you have to work with the child and the family.
Thank you, everyone. I think it's a very big topic and questions will never end. But thank you so much for your patience and all the responses to all questions. Thanks for all attendees and thanks for all speakers. It was a great day, lovely day, very informative. We all learned from it. But yeah, it's time to end. So thank you so much and see you in next events. Thank you.
Osama, very well.
Thank you.
Cheers.
Thank you so much.
Thank you. Thank you, everyone.
Thank you, Tagreed, for organizing this.
Thank you very much.
Thank you, guys.